Dr. Rao, good morning.
Hello. Good morning. Good morning, sir.
Morning.
Good morning. Okay. Good.
Good morning, sir. Hi, Nagi.
Good morning. How are you?
Fine, thanks. How are you?
I'm so far so good.
Nice to see you for a long time.
Like, come on. Nice goatee, Ravi.
Yeah.
Looks good on you.
Got to do something to keep yourself busy during these days, no?
Agree. I can see one Dr. Ravindra host. I was thinking Dr. Ravi from Bangalore is on the.
No, he's our CIO.
CIO, IT man.
Oh, okay.
Who is getting all of us connected every time.
Yeah. I can see him as a host. So I was thinking, first I saw his name. I thought, okay, it was Bangalore. Also, we have Dr. Ravindra. I think Dr. Dayanand knows. Fana. We have not bet 223 participants already on the line.
ಕೆಳಗಿದೆ 225.
ಅದು ಕೋವಿಡ್ ಕೇಸ್ ತರ ಅದು ಇನ್ಕ್ರೀಸ್ ಆಕೊಂತ ಹೋಗ್ತಾ ಇದೆ.
ಸರ್ ಇದು ಇನ್ಕ್ರೀಸ್ ಆದ್ರೆ ಬೇಜಾರಿಲ್ಲ ಸರ್, ಅದು ಇನ್ಕ್ರೀಸ್ ಆದ್ರೆ ಬೇಜಾರು. ದಯಾನಂದ್, ನಿಮ್ಮಲ್ಲಿ ಹೈ ಫ್ಲೋ ತಗೊಂಡ್ರಾ?
What about 10, Nagendra? It's very good. It's very
ಯಾವುದು?
good. High flow oxygen, ಇದು ಅಲ್ಲ ಕಂಪನಿ ಕೇಳ್ತಾ ಇದ್ದಾರೆ.
ಹೇಳಿ ಮಹೇಶ್.
It's local.
Company. ಕಂಪನಿ
ಹೇಳ್ತೀನಿ ಒಂದ್ ನಿಮಿಷ. ಯಾವ ಕಂಪನಿ?
ನಾವು ಏನ್ ಪ್ರೈಸ್ ಕೊಟ್ವಿ?
Fisher.
Stitcher. How much was it?
Fisher.
Fisher. How much was it?
2.8 lakhs per unit.
Okay.
You have any other good ones with a lesser cost?
We have at 135 model which is working very high, up to 30 liters you can give. Now it's a workhorse. It can be tried if you require more. I will send the details.
Nagendra Swami, I think Swamiji has come along with our DC. We will leave it to Mamta to start. We make the beginning.
ಡೀಟೇಲ್ಸ್ ಇದ್ರೆ ಕೊಡ್ಬೇಕಾಯ್ತು, ಪ್ರಿಂಟ್ ಇತ್ತಲ್ಲಪ್ಪ ಇಲ್ಲ ವೆಬಿನಾರ್.
ನಮಸ್ಕಾರ ಸರ್.
ನಮಸ್ಕಾರ ಬುದ್ಧಿ.
ನಮಸ್ಕಾರ ಸ್ವಾಮಿ.
DC ಮೇಡಮ್ ಅವರು ಇದ್ರ ಜೊತೆಗೆ.
ವೆಲ್ಕಮ್ ಯು ಮೇಡಮ್.
ನಮಸ್ಕಾರ ಮೇಡಮ್.
ನಮಸ್ತೆ.
Welcome to Mysore and welcome to JSS Mahavidyapita on behalf of JSS Mahavidyapita.
ಥ್ಯಾಂಕ್ ಯು.
ಕೊಡಪ್ಪ.
Mamta can take Swamiji's blessings and start.
Yes, sir. So, offering pranams to the Guru Parampara of Sri Sutturu Veerasimhasana Mahasamsthana Math and seeking the blessings of His Holiness Jagadguru Sri Shivaratri Deshikendra Mahaswamiji, I, Dr. Mamta, take the privilege of welcoming the distinguished dignitaries to the inauguration of this webinar on leading COVID-19 management in hospitals, lessons learned. First of all, I offer my humble pranams to His Holiness Swamiji and seek his blessings for the success of this event. I take immense pleasure in welcoming our new DC of Mysore, Srimati Rohini Sinduri, to this auspicious occasion. In fact, we are commemorating this event with our 105th Jayanti celebration of Dr. Sri Rajendra Mahaswamiji. And today being Mahatma Gandhi Ji Jayanti and Lal Bahadur Shastri Jayanti, it's indeed a very auspicious occasion, and to have a webinar where dissemination of knowledge and enlightenment of souls will happen. Thank you all. So I take immense pleasure in inviting Dr. C.G. Betsurmat, the Executive Secretary of JSS Mahavidyapita, as chief guest for today's inaugural function. Welcome you, sir.
Thank you.
I welcome our beloved Pro-Chancellor, Sir, Dr. B. Suresh, the spirit behind this mission. Welcome you, sir. I also welcome our Registrar, Dr. B. Manjunatha, the strength behind all our initiatives. Welcome you, sir. I also welcome Dr. P.A. Kushalappa, Director Academics, the source of encouragement and mentor for our department. Welcome you, sir.
Thank you, Mamta.
I also welcome our Dean, Dr. Colonel Dayananda, sir, Director, JSS Hospital, and Principal, Dr. H. Baswanagaudappa, sir, JSS Medical College, for supporting and guiding us during this event. I also have immense pleasure in welcoming Dr. Nagendra Swami, who is adjunct faculty and founder chairman of Medisync Private Limited, Bangalore, for supporting us in realizing this webinar. Welcome you, sir. I also welcome the distinguished resource person for today's webinar, Dr. M.D. Ravi, sir, Dr. Guruswami, sir, Dr. Sumana, Mr. Naveed Pasha, Dr. Subhash Chandra, Dr. Jairaj, Dr. Sumalata, Dr. Naveen Niranjan, Dr. T.S.S. Rao, and Mr. Lokesh. I also welcome all the eminent leaders, doctors, participants, and representations from our sister institutions and other organizations to this webinar. A hearty welcome to you one and all. Now I humbly request His Holiness Swamiji to inaugurate the webinar symbolically. I request CIO sir to kindly facilitate the inauguration.
No, madam will.
DC ಮೇಡಮ್ ಅವ್ರು ಮಾಡ್ತಾರೆ.
DCO madam will.
ರೋಹಿಣಿ ಸಿಂಧೂರಿ ಅವರು.
ಆಯ್ತು ಸ್ವಾಮೀಜಿ.
ಶುಭಂ ಕುರುತ್ವಂ ಕಲ್ಯಾಣಂ ಆರೋಗ್ಯಂ ಧನ ಸಂಪದಃ ಶುಭಂ ಕುರು दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते.
Thank you, Madam, for inaugurating this auspicious event. When humanity is guided by spirituality and divinity is the power which helps transcend all difficulties, we are fortunate to have the blessings of His Holiness Swamiji and request His Holiness for divine blessings to all of us. Pranam Swamiji.
On ಮಾಡಿದ ಆನ್ ಮಾಡಪ್ಪ ಸ್ಪೀಚ್.
I also welcome Sri Manjunath sir for this webinar. Welcome you, sir.
ಬರ್ಲಪ್ಪ ಬರ್ಲಿ. ಕೇಳ್ತಾ ಬ್ರಹ್ಮಾನಂದಂ ಪರಮಸುಖದಂ ಕೇವಲಂ ಜ್ಞಾನಮೂರ್ತಿಂ ದ್ವಂದ್ವಾತೀತಂ ಗಗನಸದೃಶಂ ತತ್ವಮಸ್ಯಾದಿಲಕ್ಷ್ಯಂ ಏಕಂ ನಿತ್ಯಂ ವಿಮಲಮಚಲಂ ಸರ್ವದಿ ಸಾಕ್ಷಿಭೂತಂ ತ್ರಿಗುಣರಹಿತಂ ಸದ್ಗುರುಂ ತಂ ನಮಾಮಿ. ಮೈಸೂರು ಜಿಲ್ಲೆಯ ಜಿಲ್ಲಾಧಿಕಾರಿಗಳಾಗಿ ಇದೀಗ 2-3 ದಿನಗಳ ಹಿಂದೆ ಅಧಿಕಾರವನ್ನು ವಹಿಸಿಕೊಂಡಿರುವಂತಹ ನಮ್ಮ ರಾಜ್ಯದ one of the dynamic good administrator and popular deputy commissioner Madam Rohini Sinduri, Dr. Belsurmat, executive secretary, Dr. Suresh, pro chancellor, Dr. Nagendra Swami, founder chairman medicine management services, Colonel Dr. Dayananda, director JSS Hospital, Dr. Basavanagowdappa, principal, members of faculty, staff, students, participating delegates from various walks of life, ladies and gentlemen. Happy to participate in this live webinar on a very special day of Gandhi Jayanti and Jayanti of Lal Bahadur Shastri to ponder over one of the greatest health challenges the humanity has faced in recent times. There is none in this world who is not affected directly or indirectly by the COVID pandemic. It is the bounden duty of every person to give whatever one can to save the humanity from this deadly disease. As Gandhiji has rightly once said, it is the health that is real wealth and not pieces of gold or silver. Mahatma Gandhiji is remembered most often than not for non-violence and truth. Many may not know that Gandhiji wrote a book called Key to Health. He practiced meticulously what he preached and he adamantly stuck to his health beliefs. Fasting and wholesome diet was his mantra for mental and physical health. Fasting for him was not only a technique but also a tool of moral coercion. He advocated natural diet, regular physical activity, and meditation as the key to a healthy life, which he practiced rigorously. On this day, 151st Gandhi Jayanti, through this webinar, all should pay respects and homage to the selfless soul. The ideals which Gandhiji preached and practiced are timeless treasures of humanity. Confining Gandhiji to India is a moral affront to his personality. He belongs to entire humanity. The racist practices in the world find a robust warrior in him against such discrimination. This is perhaps the perfect opportunity to introspect and imbibe his philosophy. The various health professionals have gathered here today to share the experience, the lessons they have learned in managing the COVID-19 challenge at the hospitals. The experiences gained, lessons learned, and knowledge accumulated needs to be documented, shared, and help others by benefiting from the best practices that were developed. The development of health system management studies has today organized this webinar for the very purpose of sharing knowledge and training the future administrators to become more equipped and skilled. We congratulate them for organizing this webinar. It is equally important to prepare for the post-pandemic world. It must be from new normal to the next normal. Is the healthcare profession and the sector going to remain the same? Is the patient going to receive the care that is due to him in the manner that is expected to be provided? Is the healthcare going to be more expensive? Is the insurance sector going to be the same, and how have they fared so far? These are the few questions JSS Academy of Higher Education, JSS Hospital, and others will have to be prepared for. We hope that experiences of the experts shared will help finding the answers to make this world safe and healthy place for all living beings. We wish the webinar all success. Om Tat Sat.
Pranam Swamiji, and indeed we are blessed to have your blessings on this auspicious day. I request Madam Rohini Sinduri Madam to speak few words, sharing her experience as administrator and giving her piece of advice for health. Please, Madam.
Good morning, everybody. This was sudden. I just came to call on the Swamiji because JSS Hospital seems to have the highest number of beds in Mysore city. So I came to request that 50% of the beds can kindly be shared with the, government. Though I would not be able to be present for the entire webinar, I would like to know your inputs because someone can document ಮಾಡಿ ಕೊಡ್ತಾರೋ ಅದು. We are finding it extremely difficult in Mysore because I've just joined 2 days back. What we are seeing is that the testing rate is really low and the death rate is really high. One of the reasons also is that the neighboring districts they are referred to Mysore. And as we all know in COVID, early detection and early admission to hospital in case there are comorbidities is very crucial. But because of people coming from neighboring districts, the death rate is also quite high in Mysore. We are also finding it difficult because as I was just discussing with Swamiji, it is very easy to buy ventilators and equipment, but getting manpower, there is a real shortage of nurses and paramedical staff. We're facing that even in the district COVID hospital. The doctor there says she needs 100 nurses. So administratively, these are the challenges because it's a cycle. Just by ramping up the testing, we are telling them we'll ramp up testing. Then if you have more positives, where are we going to send them? And in the critical cases, so we have to, this supply chain thing has to be really closed, this loop. So that is a challenge we are facing as the district administration. And also I found that maybe because of the incident which has happened a month and a half back with respect to a doctor's unfortunate incident, there has been a lack of coordination between various departments. So that is one of the challenge because you are documenting challenges mainly as a medical thing. I am sharing my administrative experience, what we are trying to, because there are so many departments doing so many things and many departments don't talk to each other. We are trying to, have them on the same page. Because if you see the cycle, we have about 5-6 apps which the government is trying to track. There is a quarantine watch, there is a bed management, there are 10 of them like this. Then there is a home quarantine app. So getting all this together is crucial for us. But I think more crucial than everything else is to have the necessary manpower at the cutting edge level. So that is a crisis we are also facing, because we do not have even the JSS hospital. It was meant for a certain kind of number of people and a certain kind of patient. This kind of situation is unprecedented. We do not have the necessary staff. I am requesting Swamiji also that maybe we can have volunteers, because there is a certain element of, religious thing when a Swamiji speaks. When we ask volunteers to turn up, they might turn up a day and not turn up another day. And they are also mentioning that you have weekly counseling from the doctors here. So I think this situation, which is very unprecedented, we all have to work together. We all have to hope for the best. Whenever the vaccine comes, whenever it is going to end, till then we all have to, sail through this pandemic. I would love to know what your inputs are. Maybe someone can compile it from your Swamiji and share it with us. It will help us as a district administration how we can improve Mysore, because Mysore has no reason to have this huge numbers, because the other districts, Belgaum is supposed to have more because it is bordering Maharashtra, which is the worst affected state in the entire country in terms of people infected or death rate and all. Mysore doesn't have that kind of a challenge. So I think it is basically a lack of coordination between, various sectors. So since I'm still new, I'm still trying to learn. I would appreciate inputs from your side also. Thank you very much. Thank you, Swamiji. Your inaugural thing was very precise. I did not know Mahatma Gandhi ji wrote that book, and his relevance also you have mentioned very succinctly and very aptly. I thank you for having me at the inaugural of the webinar. Thank you so much.
Thank you, madam, for your kind words, and definitely we would look forward to coordinate better with the commissioner and other offices, so that it is a team which will manage this situation. And the whole objective of this webinar is to have the team prepared, share their experience, so that everyone learns from whatever we have learned so far. Thank you, madam.
Yes, thank you. Thank you.
Suresh, you want to say anything? Dr. Suresh?
Respected Swamiji, with your blessings, we have been able to start this inaugural, this seminar. Respected Madam Rohini Sindhuji, the Deputy Commissioner, a warm welcome to Mysore as well as to our JSS community as a whole. JSS, with the Swamiji's blessings, has been responding and expanding responsibly, steadily and progressively. So we may have not jumped in straight away with all things and then fall back. We have been responding to the needs of the district as and when the district needed, the district administration needed the support, and we were growing, and even now every week the Swamiji has our meetings with us, and we are expanding our strengths from once if we started off with 50 beds, today we are now almost covering 300 beds, which are earmarked and moving on with the needs. And one thing Swamiji has told us is no patient will be turned back who comes to us. We have not sent back any patient so far from the hospital who has come to us looking for a care. Same way, the testing facility also is going now in 3 shifts, and all support is being extended. Today, the whole idea of this webinar was to share all our experiences, not only to the world, but to our own team, because many of the members of our hospital itself will not be really knowing what is happening in the other divisions, and particularly that mindset is there that, oh, COVID ward we should be away from. So this mindset is there in the mind of even the other professionals. So we wanted to just break this also and sensitize them how bravely, how valorly, and how courageously the healthcare team is managing this. And I think I should, at this moment, place on record my gratitude and appreciation to all the leadership at the hospital level, the director, Dr. Basavanagodappa, and the Dr. Dayananda, the Colonel Director of the hospital, the medical superintendent, and all the COVID team and other teams which have been able to do it. But for their support, this would have not been possible for us. And I am sure with Swamiji's blessings, we should be able to work with you closely in whatever way JSS system can support. I think we would definitely be able to do it. And I request our director and Dr. Principal, Director Dr. Dayanand and Dr. Basanwadappa, our principal, to prepare a small document as to how we have responded over the last 6 months and give it to you, madam. And in any other way we can support, we'd be very happy to get involved and do it, madam. Thank you.
Thank you very much. Thank you.
And as you are aware, madam, we are also supporting the trial work here. Clinical trial work is going on. So we are working on that also. Different levels we are associated, and whatever way we can strengthen the hands of the region and the nation, we are there with it, madam.
Thank you.
Clinical trials ನಡೀತಾ ಇದೆ. 2 rounds ಆಯ್ತು. ಥರ್ಡ್ ರೌಂಡ್ ಲಾಸ್ಟ್ ವೀಕ್ ಸ್ಟಾರ್ಟ್ ಆಗಿದೆ. ಎಲ್ಲ ಸಕ್ಸಸ್ ಆಗಿದೆ, ಚೆನ್ನಾಗಿ ನಡೀತಾ ಇದೆ.
You can
Continue, sir.
you can continue.
ರಷ್ಯಾದ್ದು ಬರ್ತಾ ಇದೆ.
Thank you, sir. A great leader is one whose actions create a legacy that inspires others to dream more, learn more, do more, and become more. And today we are privileged to have one such leader amongst us, Dr. B. Suresh, Pro-Chancellor, sir, to deliver the inaugural address. Request for your delivery of address, sir. Thank you, sir.
I think I just spoke that, but anyway, I had prepared something. Maybe I'll just take 2-3 minutes to tell. Respected Swamiji and respected DC Madam, our Executive Secretary, Dr. Betsur Mat, all my colleagues, Dr. Nagendra Swami, and the viewers and the health leaders and students who are listening to this webinar today. Now, today, we are not going to give you lectures today. In this session, we are not going to give you any lectures. This is only a story that we are going to share with you. This is a very good story, a very long story, and there are no special characters here. Everybody is a hero and heroine in this story. There is no separate hero, there is no separate heroine, there is no separate side actor, character actor. Everybody is a hero and heroine in this story. And this is what you are going to listen to the people today. This story is of fear. How we were afraid when Corona came, and including all of us. This is a story of fear. This is a story of courage. That how did we overcome this fear and said, let's go forward and do it. This is a story of a team, that how we work together and we try to move forward and achieve the growth which we are talking. And this is a story of valor, that we said that let us sacrifice whatever we can and still make the other people happy. This is a story of compassion. And there are many such stories. You will be going to see this, and it will be purely 2.5 hours of time for each one of you spent worth its effort, where you will see that how everyone has played a very important role, and together how we were combating the worldwide challenge which is there. And this is a simple message which we wanted to share with you today. It's not talking of our achievements and numbers here. They are all only incidental. So if this story can help you to make your own stories happen, I think our purpose would have achieved. If this story can help you to shape your future and get you ready for the next challenge that may come in this world, I think our purpose would have been achieved. If this story can inspire others, that why not we also join this battle, I think that's the purpose we would have achieved. So with these few words, I again thank Swamiji for his blessings and encouragement. And I congratulate the management department, Health System Management Studies Department, and the Dean, Dr. Dayananda, for putting this effectively, this program together to achieve this. And I'm sure this will be a learning experience for all of us through the lessons which you all have gone through. And thank you very much, and welcome you again all to this session.
Thank you, sir, for your inspirational words and always driving us from the front. Leadership is not about title or designation. It's about the impact, influence, and inspiration, and establishing trust with candor, transparency, and credit. We are honored to have with us today our Executive Secretary, sir, Dr. C.G. Betsur Mat. I kindly request to sir to speak on the occasion.
Good morning, everyone. At the outset, I offer my humble pranams to His Holiness Jagadguru, Dr. Sri Shivaratri Rajendra Mahaswamiji, My respectful pranams to His Holiness Jagat Guru Sri Shivaratri Deshikendra Mahaswamiji, Chief Guest Dr. Suresh, Co-Chancellor of JSS Academy of Higher Education Research, who has already delivered the inaugural address. Guests of honor, Dr. Manjunath, Dr. Dayanand, Dr. Kushalappa, Dr. Basangodappa, Dr. Nagendra Swami, Dr. Mamata, Associate Professor and Coordinator of the webinar, all my colleagues, speakers, participants, consultants, research scholars, teachers, and students. It gives me an immense pleasure to participate in the inaugural ceremony of this webinar, organized on the right occasion of Mahatma Gandhiji and Lal Bahadur Shastri Jayanti. His Holiness Swamiji has already, while giving the blessings, spoke about Gandhi's contribution and his concern towards the health. We pay a tribute to Mahatma Gandhi and Lal Bahadur Shastri. COVID-19 pandemic has massively disrupted our lives. Besides direct devastation of health, the pandemic has waged an unprecedented war, which is being fought unceasingly by the healthcare sector. The outbreak of COVID-19 has been declared as a major national disaster, and this pandemic has brought numerous challenges to the hospitals and hospital administrators. Countries around the world are facing the challenge of increased demand for care of the people with COVID-19, compounded by fear, stigma, misinformation, and limitations on the movement that disrupt the delivery of healthcare for all the conditions. We are very happy that the medical fraternity of our JSS hospital has risen admirably to the challenge of COVID-19. They have done a commendable work and have made a great impact in the healthcare system. Unlike several private and government hospitals, our JSS hospital has taken maximum care to establish full-fledged, well-equipped COVID care center with best possible treatment and with trained staff. Screening of the patients who enter into the hospital was started from 16th March itself, and flu clinic OPD is functioning 24/7. Total number of beds allocated is 219, and the total number of tests so far performed is more than 15,000. Today, our JSS hospital is one of the most sought after hospital taking care of COVID patients. As rightly said by Dr. Suresh, no patient is turned back. Congratulations to you all, the selfless warriors of JSS Hospital. There are so many issues and challenges associated with COVID-19. They are the lessons, they are the stories learned in the management of hospitals. They are like patients, parents, and relatives' impatience, reinfection and readmission, duration of the discharge, deaths and post-death procedures, oxygen sources and distribution, mental health and psychological considerations, pressures from public and administration, staff with symptoms and risk assessments for staff exposures in the workplace and in care settings, resource and staff mobilization and management, ensuring safety, expanded testing, stress and time management, clinical challenges, intensive and post-COVID care. All these challenges need to be addressed timely and regularly. During the current crisis, health workers who are vulnerable to the highly infectious disease are not only putting in longer hours, but also working under increasingly difficult circumstances, which affect both their physical and mental health. Already 160 of our health workers, they are affected. And this is the disease that has a number of mysteries involved compared to the usual respiratory virus. There is diminution of immunity, long-term fatigue, headaches, vertigo, difficulty with cognition, and cardiorespiratory fitness. Recovery from COVID-19 can be a struggle. Organs that may be affected by COVID-19 are heart, lungs, brain, blood and mood disorders. It is becoming evident that the cardiovascular, neurological, and psychological effects are the real post-COVID issues. COVID-19 patients who have no history of cardiac disease are showing signs of heart attack post-recovery from the infection, say doctors. People who are reinfected have more severe infection. We have applied for the convalescent plasma pheresis facility, and the inspection was already held on 24th September, and we are awaiting for the permission. The report has already reached from central government to the state government. His Holiness Swamiji has already given us directions to open post-COVID rehabilitation center at JSS Hospital, and the plans have already been finalized. We seek blessings from His Holiness Swamiji here. The crucial phase 3 trials for Covishield vaccine, which is expected to test the immunogenicity of the vaccine, has already begun at JSS Hospital. JSS is going to carry out clinical trials for Novavax vaccine also. We have lived with COVID-19 for about 7 months. COVID is fairly resilient. No other flu virus has ever spread like this, and it won't just go away on its own, as many have felt it eventually. Since lockdowns have been relaxed, more and more activities have been reopened. Data shows a steady increase in the daily average of COVID-19 cases reported. Earlier we used to say, Baduku Jataka Bandi Vidhi Adara Saheba. Now we have to say, Baduku Sankatada Bandi Corona Adara Saheba. This has appeared in 2 days back in a newspaper. I hope that this platform will come up with concrete solutions to all the issues, challenges caused, and lessons learned by the pandemic crisis. My sincere appreciation, congratulations, and best wishes to the organizers and the entire team for taking a lot of initiatives in hosting this event. Thank you all.
Thank you, sir, for your sharing your experience as well as your encouraging words.
Thank you.
Management is doing things right and leadership is doing the right things. And a leader in management does both. We have the pleasure of inviting Dr. Colonel Dayananda sir, Director, JSS Hospital and Dean, Faculty of Management Studies, to brief us about the webinar. Sir, please.
Very good morning to all of you. Firstly, my sincere pranams to His Holiness Swamiji, and also my acknowledgement of the VIPs and the dignitaries present in the webinar. Because of short of time, I'll be going little fast on this. My duty is to orient towards the webinar, which is packed with experts, my colleagues who will be speaking on very specific areas of their expertise. However, the purpose of this webinar being organized is that there is a lot of anxiety, a lot of fear in the community, a lot of uncertainty. We do not know what we are doing. What is happening is not clear to people. So what we thought was it was very relevant that we bring in what is the experience of the hospital so far, that is the last 6 months, as well as what are the established facts in terms of management of COVID and how are we managing is brought to the fore, so that a lot of misinformation or disinformation is allayed from the people and we carry on with life as before. This is the purpose of this webinar. Firstly, I will be speaking on the current scenario of the hospital, what we have been doing for the past 6 months and what has been our experience. Secondly, our principal, Dr. Basavanagodappa, will be speaking on harmonizing the academic as well as the clinical resources in the field of this thing. But it is a very fine balancing, because he is not compromising on the academics, he is neither compromising on the clinical aspects of it. So both is a very, very delicate this thing that we are carrying on, and he will be speaking on these, how he is balancing these two activities and carrying on serving people as well as the teaching goes on as before. Second, we have a very eminent Dr. Ravi, Professor of Pediatrics. He is our chairman of Infection Control Committee. However, he is also the guiding this thing to bring out a lot of guidelines while passing through the last 6 months. A lot of guidelines and protocols were established by him and Dr. Chetak, regarding how to move about keeping the Ministry of Health guidelines, keeping the state guidelines, keeping the district authorities directives on these issues. So he'll be speaking on preparing the strategy and ensuring safety. Then we'll have the major frontline warriors in our COVID fight is the nurses. One, our Mr. Naveed Pasha is our clinical instructor. He will be speaking about how it has been the challenge, how they have been taking up the challenge and how they have been serving in terms of the nursing force, which is forms 3/4 of a hospital manpower. Next, we have Professor Sumana. She would be speaking about the establishment of RT-PCR laboratories and various other tests that we have been conducted. What has been the challenges? What has been her team's efforts in bringing about quick results and bringing about quick treatment of the patients. Next, we have our medical superintendent, Professor Dr. Guruswamy. He will be speaking on managing non-COVID emergencies. This is also a challenge in terms of COVID situation. Large amount of focus is on COVID, whereas you can understand there are another 80% of the disease, which is non-COVID emergencies also. He will be speaking on that topic. Then we have Professor Jayaraj, who is a professor and HOD of pulmonology, and the major brunt is also taken by him in terms of the clinical challenges and sustenance of life in very severe patients that we are having and who reach that stage, how to manage them, how to get out of that situation, how to bring back to normalcy. This is a very important this thing that he'll be addressing on. And we have the very eminent Dr. Naveen Niranjan. He is our coordinator. He is taking the major brunt of our issue with either with the population, either with the community or with the district administration. He would be speaking on these challenges, how he is managing and how he is sustaining and how he keeping both the district administration informed as well as hospital authorities informed as well as clinical activity to go on. Then we have Dr. Sumalata. She is spearheading the intensive care in our hospital. We are really fortunate to have her, and we have another 3 or 4 intensivists with her. They are doing a tremendous job, and she would be giving you her perspective. And also to the information of all of you, we had a very critical police sub-inspector who brought in a critical state. After 10, 15 or 20 days of treatment, he went back to the community. Whole of police forces of police as well as district commissioner of our district came to the hospital to felicitate her as well as our team. So that for the good work she is doing, and as well as she continues to do so, because most constrained bed is the ICU bed today in most of the places, including our JSS hospital. She will be speaking about her experiences. Then we have Professor Subhash Chandra, Professor Head of the Department of General Medicine. He is managing the large part of 80 to 90% of the patients are in the other category, that is mild to moderate illnesses. And not only he is managing, he has brought in a lot of guidelines, how to be treated, what is the components that is required, what other specialties should be included. Time to time, he advises us in times of how do we go about, because of the number of patients are being increased, what other specialties to be incorporated. So he is doing a wonderful job, and he would be speaking on the clinical challenges during COVID. Next, we have Dr. Rao, Dr. Satyanarayan Rao. He is a well-known professor of psychiatry, and he's been on the national scene for long. And he's also spared his time to come and discuss with that. You might be seeing that we also have instances where COVID is also affecting in some way the mental faculties. We did have many patients. So he's facilitated us by having this psychiatric counseling of these patients, which is very unique in our hospital. They go around the patients, whether needed or not, go around counseling, talking to them so that there is somebody who's talking other than the clinicians themselves. So it's a wonderful job the psychiatry department is doing. I'm sure he will be able to throw more light on what exactly he's doing. And most important now is the administrative officer, Mr. Lokesh. He's managing the resources and making them available. It's very, very challenging, believe me. And especially, I'll be giving you a brief and probably he'll be talking in detail in terms of what is available, what became scarce suddenly, and government didn't have any control over these activities. So with all that, he managed flawlessly, getting all the disposables, equipments, things like that, without affecting our clinical support system that we have. Next, we have our Pro-Chancellor, Dr. Suresh, will be speaking on leadership support and future. And in fact, I should place it on record that this webinar is also his own brainchild. On his advice that we conducted this. Thank you, sir. And I'm sure he will be giving us the leadership tips in terms of how to go forward, because this is not the end of it. Probably we were not even in the middle of the activities that's happening. At last, we have our adjunct faculty, Dr. Nagendra Swami, as well as our Board of Visitors Governing Council member also. And also he was the former chairperson for all the private hospitals in Karnataka. So he will bring in huge amount of experience as well as also what is happening currently in Bangalore. And I'm sure he will be able to give us a lot of fruitful, useful tips while he is going to conclude this session. So with this, this is my short introduction to this, because we will be having very good speakers coming up. So thank you so much.
Thank you, sir. Feeling gratitude and not expressing it is like wrapping a gift and not giving it. As we express our gratitude, we must never forget that the highest appreciation is not to utter words, but to live by them. So I humbly request our registrar, Dr. B. Manjunatha, sir, to propose the vote of thanks.
Thank you, madam. It gives me immense pleasure to propose the vote of thanks. My respectful pranams to the lotus feet of His Holiness Jagadguru Sri Shivaratri Deshikendra Mahaswamiji for showering his blessings on all of us and advising us in key areas with his spiritual vision. I sincerely thank, with the blessings of Swamiji, this webinar will achieve all its objectives and goals. I sincerely thank our dynamic Deputy Commissioner for joining us, sharing our experience and motivating us. I wholeheartedly thank our Executive Secretary, Dr. C.G. Betsurmat, for his kind words and guiding us all in all our endeavors. My sincere thanks also goes to our Secretary 1, Deputy Sri S.P. Manjunath. I sincerely thank our Pro-Chancellor, Dr. B. Suresh, for his hand-holding and guiding us all along. I thank our Vice-Chancellor, Dr. Surinder Singh, who has wholeheartedly supported us and is our pillar of strength. I thank Dr. Dayanand, Director, JS Hospital, for orienting us about this webinar. I thank Dr. Nagendra Swami, adjunct faculty, and also a research person here. I thank all the resource persons, Dr. H. Basangodappa, Dr. M.D. Ravi, Dr. Guruswami, Dr. T.S.S. Rao, Dr. Jairaj, Dr. Sumana, Dr. Subhash Chandra, Dr. Naveed Pasha, Dr. Naveen Niranjan, Dr. Sumalata, and Mr. Lokesh. I thank all the officers of JSS Mahavidyapita, JSS Academy of Higher Education Research, JSS Medical College, JSS Hospital for their kind cooperation. I thank the IT team for their support. I congratulate and thank Dr. Mamta and the entire team of Health System Management Studies staff, teaching, non-teaching, for organizing this webinar, which is the need of the hour. Thank you and all. Thank you.
Thank you, sir. We wholeheartedly extend our thanks to you too, sir. Thank you. So when the going gets tough, the tough get going. And tough times do not last, but tough people do. Today we have with us distinguished luminaries who are here to share their proficiency and expertise in handling dire situations and guide us through these difficult times and instill in us the hope and confidence, as where there is a will, there is a way. Now I hand over the session conduct to Dr. Divya to take us through the sessions. Over to Dr. Divya.
Thank you, madam. Good morning to all the panelists who are present as well as the attendees of the seminar. We will be commencing session 1. Average leaders raise the bar on themselves. Good leaders raise the bar for others. Great leaders inspire others to raise their own bar. The quality of a leader is reflected in the standards they set for themselves. We have one such leader amongst us today, Dr. Colonel M. Dayananda, who has vast experience in various military units as well as in armed medical corps. Sir has held distinguished positions of Medical Superintendent and Chief Operating Officer at prestigious institutes and is currently the Director of JSS Hospital. Sir has various core competencies in hospital planning and consultancy, human resource management, and manpower planning. And with this rich experience in these areas, he has played a key role in establishment of the COVID care facilities at JSS Hospital. It is my immense pleasure to invite Sir to enlighten us on the present scenario of COVID-19 management at JSS Hospital. Sir, over to you, sir.
Thank you, Dr. Divya. Thank you.
Are the slides visible?
Are the slides visible?
Yes, sir. Yes, sir.
Yes.
Okay, thank you. Thank you.
ಅದನ್ನು ಮಿನಿಮೈಸ್ ಮಾಡಿ ಇದು ಫೋಟೋ ಇದು
Next.
ಅಷ್ಟೇ ಸಾಕು ಮೇಲೆ ಡ್ರ್ಯಾಗ್ ಮಾಡಿ ಓಕೆ.
Yeah. Thank you, Dr. Divya. So I begin my presentation. This is, you can hold that time. Yeah. So this is just to give a preamble to this discussion that we are going to carry forward. Beginning of 2020, somewhere in January, we heard of a disease, a strange flu-like disease, which is affecting the people of Wuhan city in China. And after a few days, there were many deaths occurring there. And they traced to a wet market. Wet market is a place where they sell live and dead animals. It's exotic meats the Chinese consume. So this is what they traced. And also there was a controversy in terms of whether it originated from the Wuhan laboratory and whether it was an engineered virus, not a natural virus. So keeping aside all these discussions, this is what happened. It has got a wide impact in the world. We have the mortality, morbidity. It's a pandemic after 100 years, as well as economic destruction of the whole world's economy is also happening. So this is the background with which we are having this journey. And somewhere in the February end and March, we had a focused this thing. One patient came in from one of the pharmaceutical companies near Mysore, from a small town. He came about having this infection, and even now we could not trace whether they visited China, what happened, we have no idea. And after that, there was number of patients who started coming from that place, and it became a huge talk in terms of state as well as the nation, that there was a huge focus and number of patients started coming. That is how we started having our COVID patients from there. In the meantime, we had many discussions. JSS Hospital being the multi-speciality large teaching hospital in Mysore, which about 1,800 beds. So this was a natural focus of attraction for the government also. They invited us many times to discuss how to go about what needs to be done. And there were a lot of change in guidelines also. It was every day, there are multiple agencies giving us information, what to do, what not to do. So there is a lot of confusion also. This is what at the level of government, as the level of district also. So what we did in the hospital, so initially straight away we formed a task force. The task force consists of the principal, myself, and all the HODs and other departments, which constituted, and we met time to time very frequently. That is every day in the morning around 10 o'clock, we used to meet and discuss what is the new guideline, what needs to be done, what exactly is happening. Have anybody understood the course of the disease, things like that. And whatever relevant information guidelines was passed on to the head of the departments. From there, it was passed on to the other members of the faculty, as well as the postgraduates and house surgeons and other people. In the meantime, to have this focused activity, we have what is known as a task force. The task force consists of 4 or 5 specialties. That is the Department of Medicine, Department of Pulmonology, Anesthesia, Intensivist, and Psychiatry also. These were the departments which are formed the task force, because immediate implementation is required. Whenever we had a discussion that could be immediately implemented, that is because of the task force. And that happened throughout the last 6 months, and it is happening even now. So this was the beginning of our activity. Next, please. Right in the beginning, what we did was the screening of patients. Right in the beginning, when the patient started approaching the main gate of the OPD, we segregated the patients. That is, in terms of thermal cleaning, we segregated, as well as who have got flu-like symptoms, as well as we had certain guidelines from the government in terms of having travel history or a primary contacts and things like that. They were segregated and they were directed to a different area of the hospital, where we established adult as well as pediatric flu clinic. And that we started having, and immediately we made it to 24/7. So that straight away we will segregate COVID or COVID-like and other patients straight away, so that there should not be any mix-up, because ours is a multi-speciality hospital. We would be having both kinds of patients. So that's how this was the immediate action that was taken. And also in our own staff and patients visiting us, we had strict implementation of mask, usage of mask, social distancing, and frequent hand sanitation was practiced and compulsorily insisted upon on the staff, students, as well as people who visit our hospital. There's a picture of our OPD where the screening is going on, as well as the flu clinic. Next, please. So then came about the requirement of beds where the inpatients are to be there. Initially, what happened was that the government policy was that you hold on to the patient till he is tested positive. If you feel if the patient is tested positive, that is, the test was only being done at Care Hospital. Once it was tested positive, the patient was transferred to a earmarked designated COVID hospital established by the district authorities. That was the practice for long. And after that, once they became full, they could not handle anymore. They said that we would not be able to take on any more patients. You have to establish your own facility for treating COVID patients also. In that, initially we started off in our emergency area, about 8 beds for suspected patients. And after that, we extended to the green zone and the yellow zone. These are all the zones of emergency department, which is very unique. In Karnataka, about 4 or 5 medical colleges have got full-fledged MD in emergency medicine. So this is one of them. That is why you have this zoning concept, where we utilized all those zoning beds for screening and holding the patients till we transferred the patients to Care Hospital. After that, we started accepting on our own. When the patients became positive, we were asked to admit and treat the patients in our own hospital. Then we identified about 30 general beds initially, with high dependency unit facility also was created. We further extended to another 65 beds, which along with which we had ICU beds. Initially, we established about 8-bed ICU. It became 16. Now, ultimately, we got about 34 ICU beds with 20 ventilators and 10 high-flow nasal oxygen facility. This is what this thing that we are having. So also there was a demand on us for a particular segment of people wanting special wards. Initially, we were very hesitant because it required a lot of manpower. Wherever we establish a COVID facility, that requires 24-hour activity, 3 shifts, nursing facility, doctors, everyone should be in PPE. So it is not very easy to establish. However, the demand was such that we ultimately established about 16-bed private ward. That quickly became overwhelmed. Then now we have about 34 beds which are handling COVID patients. So this is a general ward. And this is an ICU area, and this is a general ward. Next, please. So this is what we did to ultimately now we have about 234 beds earmarked for COVID activity, and rest of the beds are used for non-COVID patients. And as regards the logistics, it was a nightmare. Initially, in the month of March, we had issues about the PPE. We didn't get standard PPEs, that's personal protective equipments. Then we procured from Kundapur. There is a place called Kundapur where they are manufacturing. That got exhausted very quickly. Then we started getting from Chennai. And that because of the transport regulations and restrictions, we could not get them. So ultimately, there were a lot of deficiencies, and the cost of these equipments as well as the masks as well as PPE was hiked overnight. We used to get about 16 to 20 rupees per N95 mask. It went to 134, 150 rupees. And there was no governmental ban on these things. However, the government reduces and fixes the rates for the hospital, but there is no regulation even now on the PPE or N95 mask. It's still sold at the rates they quote. I'm just putting you on record. And we had a very acute shortage of alcohol because alcohol was not allowed. And what we used was an alcohol-based sanitizer. So there came the help of our sister institution, JC Engineering College. Professor Mallu, I want to place it on record that he's an extremely resourceful person. So he started for us manufacturing or dispensing hand sanitizers at the 1/3 the rate of what we used to procure from the market. We are again thankful to him. He continues to do so. And at the insistence and the help of Executive Secretary, we had this Jana Shikshana Samsthe, because initially there was a shortage of cloth masks also. So they manufactured in a large way and they supplied to us. And there was also issue of having the PPE was not available. So we devised our own improvised face shields as well as hoods. That was also tailored by Jana Shikshana Samsthe. We are again thankful to them when they helped us in crucial situations. This is the one that I can see you, and their donation here. The sanitizer that they have manufactured in the JCE is also shown here. Then later on came the issue of RT-PCR laboratory. Initially, the government promised that they will give you equipment, they will give a reagent, you start off. So ultimately that didn't come about as usual. Then they said, you procure the equipment, we'll give you reagents. That also didn't come about. Then we procured the equipment. Then there was an issue of recognition because it has to be recognized by the ICMR. So that took about difficult NABL accreditation. That took a lot of time. However, our Vice Chancellor was very, very resourcefully contacted the people at Delhi and ensured that we could get at the shortest possible time, keeping the constraint of the government constraints. So this is what happened. So ultimately, we started this laboratory on the 20th/7, inaugurated by the Honorable Chief Minister, Mr. Yediyurappa, and in the presence of our Swamiji. Next, please. Yeah. Okay.
No, 3 minutes.
Okay, good. So this is the result of lab tests as of today. We have tested about almost 17,000 tests were performed. 5,690 were positive. Next, please. Then as of now, patient statistics. As of now, we have treated about 9,400 in the flu clinic were examined. 1,865 patients we have admitted. And inpatient we treated so far was 1,211. There were about 115 deaths. The major cause of death is because of the late arrival of the patients with comorbidities, and many people were self-treating themselves. Many people were treated at other hospitals and later transferred to us. That is why it is enormously more number of deaths compared to the national average. Then we have 897 discharges and few were separated out. Next, please. Also, our frontline warriors, the doctors, the nurses, and our other paramedical staff, they were also affected in the course of our management of COVID patients in our hospital. The total affected were about 170, 106 were quarantined, about 64 were discharged, admitted and discharged. So far, we have been very successful in treating them, so that because that impacts the morale of the staff very much. And in spite of all this, our team is doing wonderfully well. They are high on morale. They are doing wonderfully well. Next, please. There are certain additional facilities like additional earmarked dialysis facilities that we created for our COVID patients with chronic kidney disease, as well as we provided smartphones for teleconsultation for the patients, as well as counseling that their attendants and all was done. As I was telling you, high flow oxygen systems were procured and it's working wonderfully well. And I also mentioned about psychiatric counseling. Probably Dr. Rao will be elaborating more on that. Also, we are contributing towards research. We are proud that we are part of the clinical trial that is happening in India. That's a vaccine trial that is happening in India. And also in the second listing that we are having BCG vaccine also going on in our hospital. Shortly, probably in the next week, we'll be having the convalescent plasma bank will be opened because the inspection is over. We are awaiting the license from the Bangalore authorities. And immediately after that, we'll be opening this facility. And post-COVID rehabilitation will be inaugurated next week. And this is a comprehensive center, unlike OPD clinic other people have established. Next, please. I would like to conclude by the take-home message that I would like to give is that what is known as the Japan model, where they call it as coexistence with coronavirus for a long period of time to come. There are simple 3 things that they said is keep a distance between people, wear a mask, wash your hands frequently. This is what is available as of today. Nothing else. Vaccine is yet to come.
Delhi, Nandu, how to put a video?
So this is the message I would like to give, and I thank the organizations for the opportunity given. Thank you very much.
Thank you, sir, for your words of enlightenment of the current scenario that we are facing and how the hospital has played a very important role in the service delivery for the patients of Mysore. Thank you very much, sir, once again. In the current COVID-19 scenario, there is considerable strain on the healthcare system, and the healthcare professionals have to play a very important role. People pay the doctor for his trouble. For his kindness, they still remain in his debt. We have amongst us Dr. Baswangowda sir, an academician of par excellence and an ardent researcher with excellent administrative abilities. Sir has 170 papers as well as guest lectures to his credit. Sir is a life member of 10 societies and has been involved in more than 20 multi-centric global clinical trials. He has been honored with 13 orations, 4 lifetime awards, and 4 honors and felicitations by various societies. Sir also has a distinction of being awarded as the Best Teacher Award by Lions Club of India. It is indeed an honor to have you amongst us, and Sir will enlighten us on how it is very important in harmonizing academics and clinical care and preparing the team. Over to you, sir.
Thank you so much. Good morning to everybody. At the outset, I submit my pranams to the lotus feet of His Holiness Jagadguru Shri Shivratri Rajendra Maha Swamiji. Seek the blessing from Jagadguru Shri Shivratri Deshikendra Maha Swamiji. I am happy to make my presentation for the next 10 minutes about the assigned topic of mobilizing resources and preparing the team was my topic. I just in between, I discussed with the director and incorporated harmonizing what is very, very important between academician and a clinician to take care of COVID care to the next level. Challenges are taken as opportunity in JSS Academy. Learning never stops at JSS Medical College and the JSS Academy. That's how all my colleagues, teachers who are here, 328 of them, have been doing a combined work of taking care of academics without stopping a single class. We have been able to go ahead with the online teaching, and concurrently, all of them have responded to the call given by Director of the Hospital, Medical Superintendent, and all of us. The task force called us. They are working for COVID care. So COVID pandemic did not stop clinical service at JSS Hospital. With this, we have all these credentials to the constituent colleges and the academy. Medical college is ranked 20th in the country by NIRF, and we have been ranked 3rd among the private medical colleges in India. All this is possible because of committed work by the teachers. 328 of them were working with a dedication. We all learned just now by the presentation by our director, the needs when it came up for COVID care. We were asked to establish a flow clinic, HD high dependence unit, a triaging facility till the reports are available, isolation general wards with oxygen beds, ICU care, testing and lab support system, surgical provision for both COVID and non-COVID illness, and housekeeping and dietary services. All these are invisible components which come up when we start thinking of establishing a COVID care. Mobilizing resources, we had to mobilize the doctors of various kinds, nursing staff, support service, getting adequate quantity of PPE of high quality and good quantity, which all described by our director, creating beds, segregating the zones, emergency services for both COVID and non-COVID, and medications which are rightly required in right quantity has to be procured and mobilized. This is a Herculean task. For outsider, it looks, oh, they need to admit and take care, that's all. But when you look at real requirement of mobilizing resources, it's not a simple thing. We have to deal with so many component of requirements, which we did efficiently because of efficient administrative capabilities of the director and superintendent and all the team working here. Friends, when we think of harmonizing the manpower, let us take the clinician who need to work day in and day out to take care of the patients. There are physicians, there are people working in emergency department, there are people working in intensive care, there are people working in diagnostic laboratories, there are residents who are working around the clock, taking notes and taking dictation from the clinicians. There are interns who are bridging between the clinicians and the residents, and there are pulmonologists and so on. So they had to do two things together. One, they were assigned to do a continuous teaching process for both UGs who are away from the campus online, for PGs who are in the campus working with us, and they are to be taught for what they have joined for the course, as well as they are made to work for a work which was not assigned to them. So this was a very, very important task. It's not easy. It is a challenging situation to balance between academics and the clinical care. I'm very, very thankful to all the clinicians, especially the Department of Medicine who took care of major brunt, the emergency medicine who have to receive the patient without knowing whether the COVID or non-COVID, intensivist and anesthetist who took care of the intensive care area, which is very, very important. And they all went into compassion, exhaustion because of the constant bad patients who were coming in from elsewhere, and then the outcome was not so rosy. And microbiologists, the other diagnostic laboratories, all the pathologists, biochemists, they all work together to establish the lab and take care of the diagnostic services. I'm very, very thankful to residents, all the PGs from various departments who have taken up the call given by us and they are dedicatedly working. Interns and our pulmonologists, they are all working. So harmonizing them to work together, balance between academics and clinical care was the excellent job done because of the spiritual guidance given by Swamiji and the administrative capabilities from the university and the handling the people with a dual care by the hospital administration authorities. And we have done it. Harmonizing the paramedical staff also is very, very important task. Staff nurses, procuring them, retaining them, and trying to keep their morale boosted was a very, very important task. Ward assistants, housekeeping, dietary services. It's not easy to just give a diet just to a patient like another patient. Lab technicians, other support services, and more importantly, biomedical engineering team. All this have to be there because oxygen has to be continuously be available, monitors have to be working, the ventilators have to be working. So it is simply a complex situation where many, many people are involved and they all need to understand each other what is required in the situation. They were harmonized well. That's how the outcome was so good so far. But what is important is challenges. Now, how long do you expect them to work? In the beginning, we said, oh, this is only a question of till the lockdown is over for 21 days, the disease will disappear from us. All were happily recruited with hesitancy and they were working. But lockdown 1, 2, 3, 4, then unlock period, when the numbers went on surging, the challenges were across all the stakeholders of the HR that is required for COVID care. Among the doctors, among the security, among the technician, among the dietary services agency, among the housekeeping agency, among the nurses. There are a lot of challenges in terms of how long you make them to work, what could be the shift duration, what is the diplomacy to be played when you have to have them with you working. And all these were very, very meticulously handled. So far, we have been able to do it well, but I don't know when some component will break down to the sustaining the morality may not be easy or for a long time. Procuring the PPE, the right quality, the right quantity, the demand supply mismatch, the rate went up as described by director. Beds creation area, just now we heard our DC came with the sole agenda to Swamiji asking for 50% of the beds in the largest hospital in the city. Is it just enough to ask for a bed? But where are the people to work for them? So that is what is we have been stretched to the maximum extent, stretching beyond this. Out of 1,800 bed claimed, if you have to have 900 beds, do we have manpower to manage them? It is impossible. Oxygen and ventilators, constant vigil has to be there. Water and power and finances, very, very important balancing. So all these are invisible things for the government, for the common man, which only will be experienced by us. I am thankful so far, so good. We have been able to balance these things, requirements very well. Preparing the team is a very, very important idea. Identifying the team is not a simple task. We have to identify the right person, and they have to be prepared mentally. Training them, the team, about safety and execution of the required customized skill is very, very important. Task force to review the event regularly, keep connected and revise strategy. So identifying the willing and capable team, act upon the prevailing situation, analyze the outcomes and review the policies regularly. That was very, very meticulously done by all the team here. We met regularly every day, almost every day in the beginning. Then we met alternate day, then we met twice a week. Now we are meeting as and when there is a revised regulation policy, we are meeting and taking a decision. Revising on the analysis of outcome of the review, action taken, and working strategies and care policies have been meticulously happening. That's how the outcome has been good. We need to keep in mind that there has to be always a standby team because we, as mentioned by director, 170 healthcare workers were infected. So if we go on allowing them to go away from the work and then 21 days the work is paralyzed, we need to keep thinking of standby team. So that's why all other non-specialty requirement, the manpower also were recruited. PGs from various departments, residents and interns and standby team, physicians, non-clinical departments who were enrolled, EMD physicians, intensivists, and anesthetists came in handy for critical care areas, nurses and trainees, and lab support system where technicians get infected and then there has to be a supporting staff, standby team, housekeeping. All these were posing a lot of team logistics, like what should be a shift duration for each one of them? What is the care plan strategy? What is guided by MOH? What is designed by us? What is capable by us? What is the connectivity between all the team? And then connectivity between the student, patients and the attendants of the patient. Plan for infected team member. How do we take care of them? And when do they come back to the work? What do they do when they go back to the family? Rejuvenation and counseling were very, very important. This is how it was done. And the institute came up with a very, very important bulletin, which incorporated all the good activities done by us. And amidst the crisis was the title, and we were documented. And these are the few pictures where we have a steering committee which met regularly. We have a regular review meeting by all the HODs and care task force and the stakeholders of the COVID care. Then this is how we met, by sitting apart and then addressing each other, trying to learn. We are also thankful that Hospital Infection Control Committee made all the efforts to train every healthcare personnel to take care. This is how our initial things were happening. The entrance, thermal scanning, and then flu clinic, waiting area, segregating the patient, physical distancing, screening at flu clinic, triaging, preparing the patient care, and outreach activity. Not only confined to COVID care in the hospital, our residents went to Nanjangud in the very beginning to do a survey and sampling by wearing all these PPEs in the community, went to house and survey. Our people worked in various areas in the society, and our extended activity was there. In fact, extending our lab services, and our volunteers went to COVID hospital in the beginning, and helping hand was extended to them in training their staff, and our community medicine staff went there, PGs went there and then supported them. Our residents worked day in and day out, and we are very thankful to all of them. Lastly, 2 slides, key points for successful teamwork. Frequent strategy meetings were held, and there was a receptive administration. That is very, very important for a sustained work. If the administration is not receptive, the work won't continue sustained. That has happened excellently here. So far, so good. Adequate safety measures and confidence building has to happen. Whenever they are requested, a quality PPE was provided. Adequate numbers were given. Director said, no matter, you just work, we are there to support you. That's how adequate safety measures are not there, then the workforce will not work for you. So that was provided. Committed involvement of senior faculty. I'm thankful to HOD of Medicine, Dr. Subhash Chandra, volunteered. He started the first week's round in the COVID isolation ward, and he said every unit chief will do the rounds on a weekly basis. That's how he set the thing, and he put the guidelines, and he did work. All residents were mobilized and they are posted to work. Nursing staff, very, very committed. And we need to really keep their morale boosted, keeping them, pepping up their work, and then we need to really give them some incentives additionally. Sustaining the morale of healthcare workers and health professionals is very, very important, because we don't know when the COVID is going to end. And that has happened so far, that has to happen further. We need to find the methods of sustaining the morale much, much longer, because we may have to wait for another 6 months for a good vaccine to come, for every one of us to get vaccinated and walk with confidence like pre-COVID era. Untiring work by intensivists and anesthetists is responsible for a better outcome. In spite of having a greater mortality rate, those who reached in ICU, they kept on telling, sir, we are fed up of seeing the patients worsening and not responding to our care. Ultimately, I am here to say that the efforts done by entire team here was because of careful planning, picking up the right team, and picking up the right material for the required COVID care. Quick, feasible strategy and quality training was given. That was a very, very important component, which is making our people to work with a happiness in spite of distress. Adequate infrastructure has been created, moral support has been given. We are here to convert the challenges to opportunities and overcome the challenges with appropriate, feasible policies. That's how we are one of the few centers in the country who has been selected for 3 vaccine trials and 2 molecule trials, which are now lined up for preventing cytokine storm. Hope for the safe and effective vaccine and good control of COVID for the future, for a safe future. I'm very, very thankful to HSMS, the entire people who have planned this webinar for giving this opportunity to tell the world, tell the community that how medical college and the hospital have harmonized the academicians, the clinicians, and kept going the academics as well as keeping the clinical requirement of COVID management in part. Thank you all. Be safe, be happy. Things are going to change. Till such time, let us be very, very cautious, but continue to work committedly for taking care of the societal needs. Thank you all.
Thank you, sir, for the insights as to how academics and clinical care place paramount importance in preparing the team for any situation as well as contingency. Now I hand over the moderation of the next session to Mrs. Kanakavalli.
Thank you, ma'am. COVID-19 preparedness plan involves a strategic response and preparedness plan yet ensuring the safety of frontline healthcare warriors, support staff and patients. We have here Dr. M.D. Ravi sir, a very well-known name in JSS AHER and JSS Hospital for his versatile expertise as a pediatrician, academician, administrator, and a researcher who had worked on COVID preparedness strategy formulation and implementation in JSS Hospital. Along with his 40 years of rich clinical experience and close to 3 decades of committed teaching experience, positions as Director, JSS Hospital, Vice Principal, JSS Medical College are testimonials to his dynamic leadership skills. As an ardent researcher, he has wide experience in handling various research grants, clinical trials and publications, and undergone training modules on vaccine safety by World Health Organization. With this brief introduction, I now request Dr. M.D. Ravi sir to kindly commence session 3 on preparing the strategy and ensuring safety. Sir, over to you.
Good morning, and seeking the blessings of His Holiness Sri Rajendra Mahaswamiji, and with my humble pranams to the lotus feet of Sri Deshikendra Mahaswamiji. Over the next 8 or 9 minutes, I would like to just take you through the journey that we had on preparing the strategy and ensuring safety in our hospital. This said, I must say that this could not have been done without the very able support of Dr. Chetak, who was the surveillance officer, and he was my right hand right through this whole process. Now, before we really started off getting lots of patients, our first steps that we took were prophylactic. Before we started getting 1 and 2 cases, which we were not handling, the director called us and said we should be prepared to start taking cases because we don't know when the government hospitals will overrun. So we started having strategy meetings. These were held by the director, and this is held daily with the hospital administration, with the heads of various departments who were involved, pediatrics, medicine, and so forth. A flu clinic was established. Incidentally, the pediatric flu clinic was one of the first that was established as a separate flu clinic in, I think, at least in Mysore. In the initial stages, we had guidelines which were given by the Ministry of Health and Family Welfare, Government of India. And those protocols that we created at that time, the protocols and standard operating procedures that we created were as per the guidelines that were given initially. But then, as the director said, what happened was that it kept on changing. And we had to keep on updating both our protocols and the standard operating procedures. One thing that was standard was that we needed to have some kind of sanitization protocol for the workplace, the sanitization of the equipment that's used, the place where the patient sits, all that needed to be sanitized. So this protocol was created and it was put in place. First, the HICC, the Hospital Infection Control surveillance team was trained, and then they were put into the job of training the housekeeping people as this is to be done. So we started conducting a whole lot of training programs. Training programs were conducted separately for medical staff, that is for the interns, the residents, the staff doctors. This was regarding our various new standard operating procedures which had been created for the COVID-19 epidemic, and importantly, about donning and doffing of the PPEs. Now, this is something which is absolutely new because most of us had not used PPEs, only some of the surgeons had used standard operating procedures for HIV patients. But we had most of the medical people and the interns and residents did not know about this. So we had special training programs on how to put on and take off your PPEs, and the importance of biomedical waste disposal in this era of COVID, especially the PPEs and so forth. The non-medical staff also, housekeeping, the security, the office staff, non-teaching clerical staff, etc., were trained in batches because there were a large number on personal hygiene, on hand hygiene, PPE usage in situations where they needed to use, for example, lab technicians who were taking the throat swabs or the COVID swab, the RT-PCR swabs, and we put into place workplace protocols as to how the workflow should occur so that there is no hindrance and at the same time there is no exposure of the staff. Separate training programs are also held for paramedical and medical staff nurses, like the staff nurses, the lab techs, etc. Now, the SICC surveillance team, we have a set of nurses who are trained in hospital infection control, and these people were allocated floors. Each floor was given to one specific staff nurse to supervise. Daily reports were generated on their rounds. These reports were given to the administration, the chairman of the hospital infection control, as well as the surveillance officer, that is Dr. Chetan. Now, whatever non-compliances were found, they were put into the report. And if there was a non-compliance, it was any problem that occurred later in the evening was put into the next day's report. Appropriate training was given to the people where there were non-compliances, and necessary actions were taken based on these reports to make sure that whatever problems that had occurred were corrected within the next 24 hours. Now, as I said earlier, protocols and guidelines from the Ministry of the Health were frequently changed. So reviews had to be done on a daily basis. As our director said, we had daily meetings sometimes just to review protocols. I don't remember how many times we changed the protocols or changed the standard operating procedures. It was done at least, I think we were doing it sometimes once, twice a week. And the problem was that every time we changed the protocol or changed the SOP, we had to retrain the entire set of staff on the new set of protocols and the new set of SOPs. As the number of patients increased, more frequent HICC rounds were introduced. Instead of having one daily round, we started having 2 daily rounds, and the reporting was also made twice a day. There was a special emphasis on waste management, including discarded PCPE, because the number of discarded PPEs increased as the number of patients increased, and the amount of waste that was being generated also increased. So we had to train the entire set of staff again on how to handle this a large amount of waste that was being generated. Ongoing training programs were held. We have attrition, we have people joining in. So as and when people leave, we may have to replace them. So we had a continuous stream of people joining in the form of residents or staff nurses or interns who joined. As and when they joined in batches, we had the training programs again, which was conducted by the HICC team, primarily by Dr. Chetak from the HICC team and Dr. Deepashri from microbiology. Posters for patient information on hand hygiene, social distancing, etc., were prominently displayed in all places, and the staff nurses in the outpatient department were instructed to vet the patient and see if there was a patient who was suspected who had fever or something like that. They were sent to the flu clinic. Otherwise, social distancing was maintained in the OPDs, and the staff nurses were trained as to how to instruct the patients to maintain social distancing and hygiene. Protocol for managing situations where one or more staff were positive was put in place, including contact tracing. For example, if a staff member in one of the OPDs became positive, we shut down the OPD for 24 hours, sanitized it 2 or 3 times, and the entire staff was exposed to that, was observed carefully for the next 24 hours. And entry of attenders to the wards were restricted. Number of attenders of patients in the COVID ward was restricted. Drugs were delivered to these wards by the pharmacy staff. So these measures were all put in place, and those patients who died, measures were put into place to handle the bodies of the patients who died. Mortuary staff was trained in how to handle these bodies. The nodal officer for COVID was in continuous touch with the health authorities for managing the disposal of these bodies. Now, in conclusion, the process of ensuring safety in these times is dynamic, as the disease process itself is varying. We still don't know where it's heading. We still don't know so much about this virus. It seems to be changing quite often. So protocols are being modified or changed depending upon the current scenario. We have not stopped reassessing our protocols or SOPs. We still do it at regular intervals. As the number of patients increases, as the type of patients increases, we have to keep changing our SOPs and protocols. And the hospital infection control staff from top to bottom is on continuous alert to handle emerging problems. Thank you very much.
Thank you, sir. Your talk has helped us to identify how coordinated the teamwork should be, especially in contingent situations like this. So I thank you once again, sir, and I'll continue for the next session. Nursing care towards patients depicts mother's care towards her children. Nurses' response to this crisis have moved in nursing profession to spotlight to an extent that year 2020 is greatly justified as International Year of the Nurse and the Midwife by WHO. I now request Mr. Naveed Pasha to share about the challenges faced by nursing staff in COVID situations at JSS Hospital. Mr. Naveed is currently working in training and development as clinical instructor. He is involved in planning and conducting continuous nursing education programs for the hospital's nursing staff and also coordinates NABH work from the nursing department. He has joined our hospital in 2008 and actively involved in various operational and academic activities of the department since then. Mr. Naveed, you can kindly begin the session 4 on challenging in nursing during COVID situations.
So, initially I should thank His Holiness Jagadguru Sri Shivaratri Deshakendra Mahaswamiji for the blessings, and also I should sincerely thank the organizer for giving opportunity to me to talk this estimated webinar about whatever challenge we faced in our nursing department and during this COVID. So as our contribution recognized by the 2020 year of 2020, the World Health Organization also declared that International Year of Nurse and Midwife, and we are a strongest pillar of healthcare device system, and we are also a frontline warriors in the taking the challenges. As till March, in the same aura we are continued. Then we had a pandemic strike of COVID-19. Then we took challenge as everyone did. So initially we had a staff related issues. So like initially we had a much staff related issue, like for example, it started with the lockdown. So when whole country suddenly announced a lockdown, we had a very commuted problem because most of our staffs they're depending on the local.
You have to move the slide, Pasha.
I'm moving slide. So the lockdown happens, then when a sudden lockdown, when we are unable to, our staffs are able not come for the duty because of the most of the staff dependent on the local transport. They could not able to come for duty. It was become very shortage of staff in duties. And next, most of the staff are dependent on these salaries, and their family also suffered. Even they took other work for early wages for work for an other work. And then we have essential services in our hospital. The regular OP and IP service are functioning. We should not interrupt the essential services like dialysis, and we not have any excuse. We continued the services with pulling the staff from one area to another area.
Sir, sorry for the interruption. The slides are not moving, sir. And please make it full screen.
You go to slideshow mode, you are in a preview mode. Go to slideshow mode and move the slides.
You have to enable editing.
So can you see now, sir? Slide?
No.
Stop sharing
We
and
can see the
reshare it.
slide. You can go to the top. There is one enable editing is there on the top screen. You enable editing, you click. On top, it is coming enable editing.
Okay.
So then you go to the slideshow.
No, sir.
Yeah, now you can make full screen.
Yes, sir.
Sir, or can I share the presentation from my end?
No, madam, no, madam. It is there.
Mr. Punit has gone there to help him.
You can share it, Konagoli, if you want.
Okay, sir.
Punit, Kalaivan can share it. He can talk.
It's done, sir.
That now?
Now it is.
It's good, yes.
So you just tell whenever you want to talk, next you can put, tell next, you will click it, okay?
Okay, sir. Okay, sir. Okay. So, sorry for interruption. Challenges we faced in nursing. First, I want to tell about the staff-related issues because initially when we had a lockdown, the sudden lockdown announced in the whole country, it was really committed the problem because our most of the staff are dependent in the local transport and they could not able to come for the duties, and they also did some other work for the wages. Madam, next. Essential services are full strength. So our hospital or all other IP OP services was continued. Then was our essential services like dialysis has to be continued. We have a no ASQ. We pull staff from other area or another area or less busy area to that we took the staff and we move on for the continued for the essential services. Next one. So housekeeping support, and we had a very much scarcity during this COVID time. We have a less housekeeping staff where it was really affected on our ward management program, and also it was very much difficult to give care for the patient because of the less housekeeping staff who are there in the ward scenarios. Next. And wearing PPE, I think initially wearing PPE, it was a very much difficult task for our staff. Make sure that when initially it is make uneasy and also reluctant because they has to wear more than a 6 hours, and sometimes the whole night 12 hours they has to wear the PPE without having, without they can't eat or something. They should be work with under extreme pressure. So we have faced very challenge about wearing this PPEs. Next. So next most challenge we faced about the societal challenges. Societal challenges make sure that most of the staff's house were asked to vacate because the rented house because of the surrounding people, because of lack of awareness, because of the media impact. And most of our quarantine staff who are staying in the home, their owner has to ask them vacate because of they thought they're all more prone who are suspected to transfer the diseases because of the media impact, and the we cannot come around the home because of the reluctant of the neighbors. They cannot speak of because of the impact of the media and also the lack of communication and lack of awareness about the COVID-19 scenarios. Next. And patient and family related issues. So when our hospital is started for admitting the patients for the COVID ward, it was that patient will come to hospital and it was admitted, and the attender just go away from the hospital, and we are not able to communicate with the attenders. We're not able to express the patient concern and we are not able to say about the patient problem to the attenders. And some of the patients are very much reluctant and like arrogant, and they are not at all accepting the care what we are planning. And some of the patients are more demanding, and they are demanding much that we are very much face problem. One thing I want to share about this in this challenge, one patient came and he was admitted at the night time. After admitted, he was given his his personal number only for this patient. When patient had sudden cardiac arrest, when we called the number, the phone was ringing the nearby the patient only. And patient had sudden arrest and he had died. So really that was unpredictable experience what we faced because no attender was there nearby the patient. The attender came on next day, and next day they came, and really it was very much unpredictable what we faced because when the patient had sudden cardiac arrest, no attender was there. It was really facing the difficulties. Next. So other issues, I think as per the government strategy, recently the guidelines used to change, and we have to gear up with the policies, and we have to prevent the non-COVID populations we have faced. And most of the staff are tested positives and they have been quarantined and they should be on leave. So this all faced the problem in this during COVID-19 challenges. Next slide. So how we could face? So we have could face initially administrative management support. My sincere thanks to the management. They have taken more staff safety programs. As we said, our director also said and about that initially well preparedness was done. Initially the corridor was planned about the COVID. Floor wise, they decided the wards and also corridors to just prevent the non-COVID populations. It was well preparedness was done and it was well much planned. Next slide. An adequate supply of PP. So in initial days, we never had any problem with adequate amount of supply of PP. Now director was said that about the how initially PP was very much difficult to provide.
ನಮ್ಮ ಇವರಿದ್ದಾರೆ ನೋಡು ಯಾರಾದ್ರೂ ಇದು ವಿಕಾಸ್ ಗೊತ್ತಿರುತ್ತಲ್ವಾ.
But till day we never had any shortage or we never had anything scarcity of PP. Adequate PP was supplied by the management, and also we had an leave for the staff. Also we got much leave because most of the staffs had been quarantined, then lockdown. They did not able to come for duties, and they are they leave at their absence. We make it leave, and the management was given full salary of that. And one thing I want to tell, we got all the full salary of each month because most of the other hospital has deducted by the employee salary, but in our hospital we got complete salary. And also in working with the COVID ward staff, extra offs was given after working with the 5 days, and one off extra will given because of their continuous exposure of the COVID-19 cases. Next. And training and motivation. I think most of the training session we provided for the staff because COVID-19 it is one of the uncertain disease. So most of the webinar arranged we provided, and also other concerned doctors for the department, they have taken classes for the nurses and they motivated regarding COVID-19, especially about the myths and facts about the COVID-19. That also we taken classes for them, and also we motivate them as much as possible. Next. Reassurance and benefits. I think any staff they have any symptoms, we have a flu clinic that any testings also we did for free of cost, and any patient any staff should have positive, we have a provide admissions or also adequate facilities are arranged. If they are home quarantine, the special leaves are given for them to take rest, and this all reassurance and benefit was given by the management. Next one. Motivation operation. I think I should sincerely thanks our director and also our medical superintendent, also our principal sir. So make sure all the time they motivate us to do the work, and also appreciation was taken was done. So we're doing all the care, and this is about the motivation out got by the management about these challenges what we face. And I think ultimately our patient is our ultimate goal for what we are working. So these are the brief about whatever challenge we faced and how could we face of these problems. Thank you. Thank you.
Thank you, sir, for your presentation. And in spite of all the challenges that you have faced, and along with the support of the management, it was very interesting to know how you have overcome that. And in spite of having the technical challenges, your presentation was given, and thank you so much for that. And now I request Dr. Shalini to take over the next sessions. Over to you, ma'am.
Thank you, Kanaka. Nothing is more heartbreaking than seeing a patient dying whom we failed to save. And nothing can make us more happy to see a patient getting a life by our prompt action, who was going to die in few minutes. Yes, an intensivist. We have our intensivist, Dr. Sumalata, who had also worked at multidisciplinary intensive care unit in Manipal Hospital, Bangalore. She is a receiver of scholarship from Foundations for Excellence, an American NGO. Today, she is going to talk on intensive care journey so far. Over to you, Dr. Sumalata.
We have changed our pattern of presentation of there.
Dr.
Suma, your slides are seen, but you can go to slideshow mode. You can start presentation. Nice.
We are not able to hear you, Sumalata.
Dr. Sumalata, please unmute.
Suma, please unmute and start. Your slides were seen earlier, but now you've gone back to review mode. To the notice of others, there has been slight change in the order of presentation because they want to finish the clinical scenario first and then take up the lab diagnosis later. Suma, you can unmute and start presentation. You're still not audible, Suma.
Do you have any earphones or speakers attached? Then you have to remove it, unplug that.
Still not audible, Suma. Are you in the hospital or? Okay, you can't know. Phone madilla.
Maybe we can continue the next talk. In the meantime, she can set right the speaker issue.
Can start with Subhash Chandra. Shalini, can invite Subhash Chandra?
Yes, sir. I'm ready, sir.
Yes, sir. The good physician treats the disease. The great physicians treat the patients who has the disease. This is one, Dr. Subhash Chandra, who has made a remarkable name in the city for his passion for offer patients healthier living options. He possesses profound knowledge and always updated and upgraded with advancement in the field of medicine. Today, he is going to speak on clinical challenges during COVID. Over to you, sir.
Sir, I am audible?
Yeah.
My screen, I think.
Yeah, you are
yes.
audible and your slides are seen.
Yes, sir. Okay, sir. Good afternoon to all. At the outset, I submit my humble pranams to Lotus feet of His Holiness Swamiji. So, respected dignitaries of today's webinar, ladies and gentlemen. Next 8 to 10 minutes, I am going to share our experience in managing mild to moderate and less severe cases of COVID-19 and the challenges we faced during this journey. The objectives of COVID-19 patient management, preventing them from progress to more severe manifestation and cytokine storm, and landing to ICU care and ventilator support, monitor for respiratory distress and other organ dysfunction, managing comorbidities appropriately. So this is the statistics of the COVID-19 patient in our hospital. Our director has shown this in detail. Total OPD cases so far is 9,153 and inpatients were 1,777, excluding the direct admission to the ICCU care, COVID ICU care. So for this enormous work, I think I take this opportunity to congratulate and compliment all my colleagues, all unit heads, for associate professor, and senior assistant professor, and all our PGs in carrying out this hurricane responsibility. And I request them to continue their patronage towards this work in managing the COVID-19 patient. And also I take this opportunity to thank the senior residents of orthopedic surgery, and also off late in the fourth floor COVID isolation ward, will be taken care by other faculties of the department like surgery, orthopedics, and OBG. I thank them also. I take this opportunity to thank them also. So age distribution of our patient is this table shows that the most of the patient, about 61%, constitute more than 50 years. So you can look at this table. You see that less than 30 years, hardly you can able to see some patient. Out of 1,777, only 62 numbers were in the less than 30, and most of them in the middle age or in the elderly group. So those who are in the middle age with associated comorbidities like the obesity, hypertension, diabetes, chronic kidney disease, they are more prone for this COVID infection. And also elderly people also more prone for this COVID infection. So this is our pediatric colleagues managed in their pediatric ward. There are about 52 cases of suspected cases of COVID patient were admitted in the pediatric ward. Out of that, 13 were confirmed, and no death has been reported in that. This is a very important finding. One has to note it that there is no death from the pediatric patient, those who are admitted as a COVID confirmed or suspected case. And they also screened 47 newborn babies for COVID. All are negative. So the degree of increase in the pro-inflammatory cytokines in COVID-19 is higher as induced by other viruses. Especially this effect is more pronounced in older age and comorbid conditions. The reason why this effect is less pronounced in younger age group may not very clear, but it could be due to immaturity of the immune system and the predominance Th2 immunity than Th1 in this group. What is this Th2 immunity? It's a thymus, this T helper cells type 2 immunity. It is a predominant in the younger generation, and this T helper cells type 1 immunity is in the elderly people or in the middle-aged people who are having this comorbidity like diabetes, hypertension, obesity, and chronic kidney disease. So this, because of this reason, along with this reason, it may be in the elderly people, those why they are more prone for COVID infection, and also more severity, more morbidity and mortality in the elderly people or in the middle-aged people with associated comorbidities due to pre-existing subclinical and subtle inflammation represented by increased high sensitivity CRP in these groups. So the one good thing is all our pediatric patient and adolescents and adults, young adults less than 30 years, have got a very less chance of infection by the clinical manifestation of COVID-19. And the severity of the infection, if it occurs also, the severity of infection is very less and mortality is almost negligible. But they are all these the pediatric patient and adolescents and adults, they are all super spreaders. They may likely to have a large amount of subclinical infection. That's why the government of India has taken the initiative from the October 3rd, 15th onwards. They are opening all the schools and colleges. Probably in this context, we may likely to have exponential increase in the frequency or in the incidence of the COVID-19 infection by November end or December, probably because of this, because all the children go to the school, they may not have a life-threatening infection or this one, but they come back and they spread to their grandma, grandpa, and their parents. So this is the the sex distribution of the patient who are admitted in JSS hospital. So about 72% of the males have been admitted and only remaining 28%. So it's a the disease has got a very high male preponderance when compared to the females. So there is explanation for this. The severe COVID form has significant sex disparity. with high fatality among the males than the females. Incidence of COVID-19 has also been higher in males compared with their female counterpart. This trend could be attributed to better response and robust immune system in the women. Sex hormones plays an important role in the immune response, with estrogen is considered as immune boosting and testosterone is considered to be immune suppressing. Additionally, an important protease involved in the viral entry, that is transmembrane protease S2, is regulated by the androgens. The age-associated decrease in sex steroid hormones like estrogen and testosterone may mediate pro-inflammatory increase in older adults that could increase the risk of COVID-19 adverse outcomes. So even among the females, those who is having a premenopausal, that is postmenopausal women have the higher risk of the COVID infection and severity of infection because of the decrease in the estrogen level when compared to the premenopausal women. So this systematic review and meta-analysis of sex-specific COVID-19 clinical outcomes showed that men with COVID-19 are more likely to have a severe disease compared to women and require admission to intensive care unit 71 versus 29 in female. And death rate is also in men is around 69% and women is around 31%. So this is our gynecology, that is obstetrics department colleagues have treated COVID-19 positive pregnant woman patient around 29. So out of this, they continued pregnancy about in the 9 numbers and delivered LSES 13 members, and no death has been reported. Once again, it's a very good the point for the patient who is having COVID-19 infection in the pregnant woman. So they will have, when compared to the other viral respiratory infection, the COVID-19 infection has got a better prognosis in patient or in pregnant woman. So this because the pregnant woman with SARS-CoV infection, they have predominance Th2 response. The Th2 response is thymer, this T helper cells type 2 response has got a anti-inflammatory cytokine milieu when compared to the Th1 response. They have got a pro-inflammatory cytokine milieu. So this accounts for lower incidence of maternal deaths. These are the symptoms we come across in our patient. The commonest breathlessness and fever. It is universally same. I think it's a national and globally it is the same. In addition to this, you have got extrapulmonary manifestations like myalgia, fatigue, and diarrhea, and the anosmia in some small percentage of patient. Very rarely you come across in a ageusia, that is a change in the taste. So this is really challenging for off late for all our treating physician, especially extrapulmonary manifestation patient comes directly to the medicine OPD, or they roam around for other departmental consultation. And when they come, if they say that they have got a elderly people, they have got a other comorbidities, as I told earlier, if they, with this symptom they come, if we say that, please you go to the flu clinic and get it done, the investigation, or if you require admission to be in a suspected ward. So it is very difficult. It is really challenging task for the physician and other consultants for convincing them and channelize them through the flu clinic if suspected to get admitted, or if they require admission, get it to the admission to the suspected ward of COVID. If it is confirmed, it can be treated there only, or if it is non-confirmed negative, then it can be taken to the appropriate care. So this is very challenging. One of the challenge we are facing at present. And this comorbidities, hypertension and diabetes is the commonest comorbidities, almost runs parallelly about 55 to 60%. And next to that is a coronary artery disease and CKD and the CVA. So these comorbidities patient, they may not come like classical cough, fever and other things. They come with vague weakness, fatigue, generalized weakness and aches and pains. So you should be very cautious. And the thing is, these are all the extrapulmonary manifestations of COVID. So it is no longer specifically restricted to the respiratory tract infection. So it is a multi-system disease. They can have neurological manifestation, they can have a renal manifestation, hepatic manifestation, and they can have a thromboembolic manifestation, so on. So it should be, all consultants should be aware of this, the extrapulmonary manifestations of the COVID, and you should always suspect, and you should always see that any patient comes to you, you should always take that all the universal precaution, taking that any patient comes to the hospital or any general person, we should always maintain the social distancing and maintain the sanitization process and maintain the PPE care and other thing, whatever the level of PPE care we require at various level, we should follow that so that we can prevent and also we can help the patient to appropriately. So when the patient admitted to the COVID isolation ward or to these COVID zones, so we always do some of the routine investigations like chest X-ray, and we are going to do the renal function test, pulmonary, that is liver function test, and inflammatory markers. Though they don't have the severe disease or moderate disease, even asymptomatic patient also will do this, and to know that basal levels of these inflammatory markers. So all of you know that the patient will have severity of the disease and more morbidity and mortality, not because of the primarily because of the virus infection itself. It is because of the release of the inflammatory markers and cytokine storm and multi-organ failure. Patient usually have an increased mortality and the morbidity. So in our patient, we did it. The inflammatory markers showed that a marked rise in inflammatory markers that is commonly come across is a very cheap, and it can be done at any level. It is a neutrophil lymphocyte ratio that showed that lower lymphocyte, that is lower leukocyte count and lower leukocyte count, and marked rise is seen in about 33%. And D-dimer is the one which is a marker of inflammation, and it's a marker of pulmonary embolism. These patients are more prone for pulmonary capillary clogging and pulmonary embolism. So many times patients die of this problem. So, and it's a marker of inflammation, it is a marker of severe disease. So about more than the 1 microgram is seen in the 17% of the patient. Other inflammatory markers like CRP, LDH, ferritin also increased in a significant number of patients. So this original article from the Suzhou, China, that's a retrospective study that showed that dynamic change in NLR and D-dimer level can distinguish severe COVID-19 cases from the mild to moderate cases. So this is one of the challenges our physicians faces. So whenever the patient comes to us with a ILI or SARI, so clinically it and radiologically it is typical of COVID. So what the globally described, and even locally we are all also experienced by this time. All physicians are experienced, but when you do the RT-PCR is negative. So the sensitivity of the RT-PCR is around only 70%. Somewhere around 5 to 40% of the false negative RT-PCR can come, the nasopharyngeal swab in the first incidence. So this is a very challenging situation for us when we admit in a COVID isolation ward or the COVID ICU. So patient attendant and patient himself or herself can question, I am negative, why you are continuing here, why you are treating like a COVID? So this is very, very challenging situation. Counsel them regarding this and possibility of a false negative, make them to understand it is a very challenging situation. So we have come across second swab positive in 8 patients, third swab positive in 5 patients, and 4th swab in 2 patients, and even 5th swab also positive in 1 patient. So in some patient, nearly about 8 patients, all whenever we get a RT-PCR negative, it is a viral bronchoanemia like picture is there, both clinically and radiologically. We always do the throat swab for H1N1 also, because almost they are all mimicking like that, and we start treatment for them with that oseltamivir for that patient. So in spite of all this negative, but all this radiologically and clinically, it may be a COVID. So we are considered as a clinically, it may be a COVID only in that patient. So mainstay of treatment in our ward is the steroid, that is a dexamethasone or methylprednisolone 60 mg, steroid dexamethasone 6 mg. So mainly this was started in all patients who developed hypoxia, that is the oxygen saturation less than 95%, and patient who got infiltrates in the lung and biomarkers are increased. And it has been shown that in the literature from the past 7 months, it is the mortality benefit. It has got a mortality benefit. Starting the dexamethasone or steroids is a mortality benefit. Only thing is, if the patient has got comorbidities like diabetes, it should be managed appropriately. Second one is remdesivir. It has got a clinical benefit. proven clinical benefit across the globe. So we are going to give, so when you are giving the remdesivir, initially we had a lot of problem in procuring this, non-availability, not easily available. So we are judiciously use this remdesivir in a particular patient who has got a progressive increase in the inflammatory marker, or increase in the infiltrates in the lung, or progressive increase in the oxygen requirement. In that case, we used to, since last 4 to 6 weeks, we are getting this remdesivir easily available in our pharmacy and in the market. So we are using liberally in all patients. And low molecular heparin is one of the common component of the treatment of the COVID patient who are admitted here. And by giving this low molecular heparin, we are going to tackle the pulmonary capillary clogging, pulmonary embolism, because most of the patient will die of this. And also the low molecular heparin will downgrade the inflammatory markers. So by giving this low molecular heparin, we are going to hit the 2 birds with a single stone. So, and oxygen is one of the important component of the treatment of the COVID-19, especially who develops oxygen desaturation less than 95%. We will try to maintain above 95% and above. And those who have got the less than 90%, they have got severe hypoxemia. So we keep monitoring with the inflammatory markers and keep monitoring meticulously for them. If it requires, the worsening is there, they are not maintaining even with 8 or 10 liter, ABG is worsening. So we will shift the patient to COVID ICU. Other drugs like azithromycin, treatment of comorbidities and other supportive measures. So the role of HCQS in this one, we are not used. Very few patients are used with HCQS. When you are giving remdesivir, you should not combine the HCQS with the remdesivir. And favipiravir doesn't have any clinical benefit. It has got more the toxic effects rather than this. And we are not using the favipiravir. And the other drugs we can use is doxycycline, ivermectin. Ivermectin has got some benefit. So some of the few patients have received ivermectin. So one important thing is when giving oxygen, not only correct the hypoxemia, it also improves the inflammatory markers. So oxygen requirement was given in 43% of patient, and remdesivir is given in the 5 days of course in the 33% of patient. So few patient, about 15 patients received 7 to 8 days. Very rarely some 2 patients are received more than say 8 days, that is around 10 days. So outcome of our patient management is 88% were recovered completely and discharged, and 2.4% of the patients were expired in the COVID isolation ward. That is now it comes to constitute about 18 numbers. So most of these patients, because of the sudden acute coronary event, must have died. And number 2 is most of these patients, they are admitted for some other purpose in the other departments, and they are in the palliative care. They are too elderly, they are in the palliative care, and because of that, they would not able to shift them to COVID ICU and give other supportive. Because of that, there may be around 18 number of patients are died in the COVID isolation ward. And out of this, remaining around 54 patients were shifted to ICU, that constitute about 6%. Out of this 54 patients, 39 patients after recovery from their critical illness shifted back to the isolation ward, and about 14 patients were expired in the out of 54 patients who are shifted to COVID ICU, they are expired in the isolation, the COVID ICU only. So in conclusion, we are in the process of learning about this disease and trying to identify the intervention that could slow this pandemic. Even though the virus affects both women and men appear to have disproportionately higher rates of mortality. Thank you very much for the opportunity.
Thank you, sir. Thank you for creating an awareness about who.
You have muted, Shalini. You have muted, you are not heard.
Thank you, sir, for creating an awareness about who are going to prone more for COVID-19 and also the line of treatment for COVID-19. Now I hand over to Dr. Sumalata. You're not audible, Dr. Sumalata.
Madam, if you continue to have problem, I think you can use a phone and connect through the phone and talk, madam. And one of us would present it. No, connect through the phone from the link.
Dr. Subrata, you can do one more thing. You can log out and log in again. So that will be easier because sometimes when you're logged in, you may not be able to connect properly. Just follow the same. When it says join, just join. It will lead you back to the system. And I think then you can first talk and then put the slides.
Suma, stop sharing the slides, log off, again log in, and follow as Prosi mentioned. Yeah. Subhash, it was a very, very informative presentation, Subhash. Nice data. The simple analysis has given a lot of information. Thank you so much. And I think our director was commenting that each one of those data itself can be a topic for thesis.
Yes, sir. Yes, sir. Yes. Okay, sir. We'll consider.
It was a very good talk, Dr. Subhash Chandra. Excellent.
Thank you, sir. Thank you very much. Sir. Thank you, sir.
And different type of protocols that you followed and insight to many people. I think it will help them. And even for the young students who are seeing, they can understand multiple approaches of how to manage such a crisis. They have been listening to so many speakers sharing their rich experiences. I think that's very, very important for young students particularly.
Thank you very much.
Sorry for the interruption. Now, I'll hand over the session to Mr. Roshan. He is going to continue with the other sessions till Dr. Sumalata will comfortable with her PPT.
With Suma's presentation, Sumana's presentation. Till such time, our IT team can go and help Sumalata. Somebody can request Sumana to start her presentation.
Yes, sir. I will go ahead with that, sir. Thank you, Dr. Shalini. The present moment dive for microbiologist who plays a pivotal role in diagnosis of the pandemic. Microbiologists are paying attention to diagnostic tests being used to identify people for the infection of COVID-19. On this note, I would like to introduce today's speaker, Dr. M.N. Sumana, Professor, Department of Microbiology, JSS Medical College. She has worked in the field of HIV/AIDS, hospital infection control, antimicrobial resistance, and currently working on COVID-19. She has bagged many awards, including Mother Teresa Award, presented and published over 60 scientific papers. I request Dr. Sumana to start the session on expanded testing during COVID, creation and operational challenges. Over to you, Doctor.
Thank you, Dr. Sujay. Seeking blessings from His Holiness. I thank the university authorities and the hospital authorities for giving me this opportunity. I'll be talking on the challenges that we faced while establishing the laboratory and also while running the laboratory. Now, the moment the COVID started, everybody was scared. It's like a baby when it sees a devil or a monster, the way it reacts, that's the way everybody reacted for COVID-19. And there was a stage of denial. No, we won't be able to do that. We will not start. That was the reaction from many of the staff. And they were scared that everybody would get infected. And they feared that their family will get infected and they will lose the family. But when we decided, despite all this, when we decided to start the lab, we had to face and put up ire of various other people within the department and outside the department. And then we said, work is more important. Will to work dominating the fear. We took up the job. But in the fear, crossing the hurdles with the weight of fear was a tough task for us. And then we all said with determination, let us inhale courage and exhale fear. And now with our commitment, management very firmly stood with us and they gave us all the necessary infrastructure and the facilities, and especially the biosafety facilities required for all the employees, especially the safety of the employees. And then we had to prepare for NABL accreditation. Without the NABL accreditation, we could not start the lab. So it took us nearly 1 month for us to prepare for NABL accreditation. Meanwhile, we started setting up the laboratory with all the equipment and the necessary infrastructure. And then we prepared for COVID accreditation. And we faced the pre-accreditation on Saturday. And they said, all your infrastructure is sufficient and it is good, but we are not going to give you accreditation directly for COVID-19 testing. You have to take accreditation for some other RNA virus, and then you have to apply for NABL accreditation. You know, we were taken aback and we didn't know what to do. It took us 1 month to prepare for NABL accreditation. Now we had to go through the process again, but we all decided and worked hard and did it within 3 days. And then we approached the NABL authorities, asked for a date for final assessment. We faced the final assessment on a Sunday, which was a solar eclipse day. Many people discouraged us. If you do it on this day, we are going to face bad consequences. As it is, there was the cloud of fear amongst everybody. But we said, no, we will do it and we can do it. We shall do it. But the day was very stressful when we took the assessment. Assessors cooperated very well with us. And within 3 days of assessment, we got the accreditation and permission from ICMR. Even without the permission from ICMR, we could not carry out a single test. And we started the test on Ashada Friday. People said, Ashada is not an auspicious month, don't start on that particular day. You start during Shravana. But we all said no, we put our foot down and we started the laboratory with the blessings of His Holiness and support from the management. And our Holiness pumped in lot of confidence to us. He gave a good mileage to the inaugural program by inviting the Chief Minister, Health Minister, Union Health Minister, and the Medical Education Minister. And with that, we could start off the lab. And with these blessings, till today, we are doing well. This is our COVID lab, where we have all the biosafety measures. This is our PCR equipment and our biosafety cabinets, etc. And we were always supplied with all the personal protective equipment. We had no scarcity. And that's how the management has cooperated with us in preventing the infection to any of the staff working in COVID lab. And another important person which I would like to thank is the housekeeping staff. Everybody feared to work with COVID. Doctors, nurses, technicians, everybody feared. But this lady, her name is Soumya, she came forward and not even a single day she has complained about anything. We trained her how to handle all the infectious material and how to discard it. Until date, she's done a wonderful job and clearly deserves an applause to Soumya. This is another lady, Renuka. Transportation of the sample from outpatient and inpatient departments without any hesitation. She has done a wonderful job. Every half an hour, she would bring the samples from the flu clinic to the laboratory, and she used to run literally to give us the samples in time. So I thank her also. And the irony is, when we started working in the COVID lab, we were managing, but what happened was non-COVID staff started getting infected. People who feared the most got infected. People who took a lot of care got infected. Nobody knew what to do, how much of care to take. And all these were community acquired infections. From their homes or their neighborhood, they had acquired the infection. But this did not deter the doctors in our lab. All the microbiologists worked round the clock and they did whatever was required. I'm really very thankful to my staff for giving all the support. But every time somebody got infected, there was always an amount of fear, thinking that we would get infected. The staff getting infected one after another, the challenges we faced were to manage the routine diagnostic work. The non-COVID staff started getting infected, and we had to pause some technicians and staff working in the COVID lab to the non-COVID diagnostic work. And then sanitation of the lab every time a staff got infected. And the major challenge was to keep our technicians motivated and all the staff motivated. And slowly, everybody got an impression, yes, everybody is taking good precaution and all the personal protective equipment are intact and they're supplied in time. And COVID lab is the safest place to work with. So people volunteered, they came forward to work in the COVID lab. Initially, they were reluctant to work. They came forward and they were really happy for giving that good service to the society, which is very gratifying to them. I have to mention one, Mr. Niranjan and Nagesh and all other technicians in our laboratory worked very hard and they very efficiently managed to process the urgent samples early. My everyday prayers would be, God, don't give any kind of COVID infection to any staff working in the COVID lab. Otherwise, people get demotivated and I would not get any staff to work in the COVID lab. My prayers were answered. Till date, we have not seen any staff working in COVID lab having got infected with COVID-19. We hope we continue to be blessed with His Holiness Swamiji's blessings and Adi Jagadguru Sri Shivratrishwaru's blessings. We continue not to get infected. Now the confidence which was like this, initial stage, our staff were like this, in this state, slowly they built up the confidence and they became like this. Now they're ready to face the challenge and tide over the crisis and they're ready to walk on this tightrope. That's the kind of transformation we had in our staff. And as we functioned, reaching to the numbers required was a great challenge. Initially, we had manual extraction. To extract 96 samples, it took us 3 to 4 hours. And then to run about 190 or 200 tests, it took us nearly 10 to 12 hours. Then after that, the data entry and dispatch of the report, we worked for more than 12 hours a day. And then we worked many times till 10 p.m. in the night. And at gunpoint, government samples were dumped to our laboratory. We were not in a position to refuse the government samples. And we worked day and night, but still people complained that we're not getting the reports on time. It took some time for us to streamline the work. With the cooperation of our director, medical superintendent, and the purchase department, we could streamline. And these were the effects that we used to face every day that we worked for more than 12 to 14 hours. Everyday headaches after we went home. We could not cater to the needs of our family. And our respiratory tract would go dry. And then in the morning, we would have some throat congestion. And we used to fear every day morning, yeah, have I got COVID-19? That pseudo fear of infection was always there. And little bit of tiredness, again, we attributed to having got infected with COVID. With that fear, we continued working But this automated extraction machine came as a gift of God to us. I'm very thankful to our management for giving us this. This hastened the process of testing. So this increased the speed. But data entry is a tedious process. Even today, our director provided the data entry operators for us. After we report with all the data entry operators, it takes 3 to 4 hours for us to complete all the formalities of data entry into the ICMR portal and various other formats. Different government authorities ask us to give the reports in different different formats. So it took us a lot of time. Though just PCR takes about 1.5 to 2 hours, the preparation for it and after the test is over, the release of report took nearly 8 hours for us to release the report. People just think it takes only 2 hours. What is there in giving the report? It's not as simple as that. And we had this challenge of managing patients walking directly to our lab. So many patients and patients' attendants who would have got infected would directly walk into our lab and ask for the report. We were also scared of getting infected. Security was posted, and then media people came now and then. They were asking multiple questions and nonsense questions. And travelers traveling abroad or various other places wanted the report in different formats, and we had to cater to their needs, giving the reports in different formats. And digital signature would not suffice. They wanted the sign and the manual signature. And another challenge we faced was the reports of the dead patients. No, we have to empathize with the patient's family. Otherwise, the body would not be released for the family without the COVID report. We can't be apathic like this. We have to empathize. We can't be completely sympathetic. Otherwise, we would get drowned. So we have to empathize with them, see that we are safe. At the same time, they're helped. So they are given whatever help that is required. So this was another challenge. While the positive side of doing all this, the gratitude in the voice of the patients when we release the report is so gratifying, and it's worth taking all the risk. We all developed a lot of patience and endurance. We learned a lot of lessons, and we developed a lot of confidence to tide over the crisis. Now we are ready to face the pandemic. And this reinforced the culture of teamwork. It's not a single person who can do it. It's just the team that can manage the entire show. But the situation is not as bad as we expected it to be, because in our country, we are seeing a lot of immunity. The progress of infection is pretty slow, not like the Western world. If it were to spread like the Western world, all our hospital would be choked and we would be running helter-skelter. So that would be the problem. With the blessings of God, we are able to manage. And also, we have good recovery rates. So that's the positive side. These are the new normals, which I would not like to tell everybody. All of you know it. Till date, we have carried out more than 16,000 tests and more than 5,000 patients are positive. And after this RT-PCR testing, we started antigen testing. We also introduced interleukin-6 inflammatory marker testing. And we have now started the antibody testing also. We'll be shortly starting IGRA test for BCG vaccine trial. So for vaccine trial also, we are all managing to receive the samples and carry out the test. End of the day, I know we have light at the end of the tunnel. We have to be hopeful. There's no other way to keep ourselves motivated. So vaccine is around the corner. It will come out soon. And some antiviral drugs are under trial. So with these two life-saving measures, we hope to have light at the end of the tunnel. Thank you very much for giving me this opportunity. Thank you all.
Thank you, Doctor. for explaining on establishing.
Just a second, please. Just a second. I would like to add one or two factors. Our RT-PCR laboratory has supported not only Mysore district, they have supported Ramanagar district also. Huge number of samples were handled by her in her about 670 samples from Ramanagar was handled by her, as well as 12 private hospitals in Mysore was handled. All the major hospitals, including Narayana Hrudayalaya, Apollo, nobody had laboratory. At that time, 14 hospitals total were supported by our laboratory, as well as by a special request from the DC of Mysore, we have handled the largest number of police personnel in our hospital. This is just to put it on record. Thank you.
And just now during the webinar, I got phone call from the DC office. They said they will give 200 samples every day for us to do the testing. And they're asking us to enhance the testing capacity. We'll shortly do it with all your cooperation and your blessings.
Yeah, certainly. I think we need not to enhance. We have the capability to do another 200, in fact. So please do it. Wonderful work. Thank you.
Thank you, sir.
Thank you, Doctor, for explaining on establishing the COVID lab and the hurdles that you have gone through. Appreciate you and your team's commitment to overcome the challenge. Thank you, Doctor. A crisis situation is created by the unprecedented pandemic COVID-19 everywhere, especially in hospitals. Managing hospitals amongst this dilemma have become an intimidating task. He is one of the senior most doctors in our hospital since its inception in 1981. He has worked at various capacities. I'm honored to introduce our beloved MS, Dr. Guruswamy, Medical Superintendent, Jesus Hospital. I request Dr. Guruswamy, sir, to start the session on managing non-COVID emergency, keeping the system going. Over to you, Doctor.
At the outset, I render my pranams to His Holiness Jagadguru Sri Shivratri Deshikendra Mahaswamiji. Good afternoon to all the listeners and participants. So, from the COVID area, let us move on to the non-COVID area. From morning, everybody is listening to non-COVID, COVID. I think let us move on to the non-COVID area. So, before I start, I would like to say that, slides please.
First open
MS ಅಂತ ಇದೆ ನೋಡಪ್ಪ. MS ಅಂತ ಇದೆ. ಅದೇನೆ. Yes.
Yeah. Slide show.
Slide show.
Are the slides seen?
Are the slides seen, sir?
Yes, sir. We can see the slides.
Okay, thank you, sir. Thank you. So let us go to the non-COVID area. So it was again a task for us to go into this non-COVID area. So just I would like to quote that start by doing what is necessary, then do what is possible, and suddenly you are doing the impossible. This is what Saint Francis said. So he was a Catholic Church saint, and before he became a saint, he was having a luxury just like our Lord Buddha. So he said that, so we try to manage the COVID emergencies first of all. Now we started drawing our plans point by point in order of importance and keeping a deadline to achieve these plans. So as you have heard a lot of things regarding the COVID-19 pandemic cases, and we created a separate COVID wing. And then we started creating an exclusive zone for non-COVID patients, because there was a lot of fear among the patients who came to the hospital that this hospital being admitting the COVID positive cases. So can we go there? Can we become positive for these? That was the type of anxiety these patients had. So we started mobilizing our medical, paramedical, and supporting staff, because they were also having the anxiety and the tension regarding the treating the not only COVID, but the non-COVID patients also. And we have this most important thing is we started orienting all the healthcare workers, including our doctors community, paramedical community, and the supporting staff. Because when once they came to know that there are patients who have been positive, and there were patients, attenders who were with them. So these patients, attenders used to come along with the patient. And they used to come to the hospital, they used to come to the administrative area, they used to come to the wards. So all these areas, they were quite, it was difficult for them to assess whether this patient is going to be a positive patient or a negative patient. So that was also again there for our healthcare workers. So during the lockdown, what we did was we started having this mobile consultation with the patients, because during those times, none of the patients were ready to come to the hospital. So we introduced about 5 telephone, especially mobile phones, and we give this to the media so that we gave especially for about 5 major departments like medicine, surgery, then pediatrics, then orthopedics, and then even the psychiatry also. So a lot of phones started coming to these mobile consultation. So patients were asking various questions regarding the COVID as well as the non-COVID area, saying, sir, can I come to your hospital? Can I get treatment for my appendicitis? Can I get treatment for a cardiac problem? See, all these were being asked through the phone. So somehow we were able to manage those patients, and we were able to win their confidence that you can come to this area, because entirely the zone is separated. The COVID zone is entirely separated from the non-COVID area. You can come, you will be screened, and accordingly you will be admitted and treated if there is a need. So that is how we started gaining the confidence of patients who used to come to the hospital. We not only gained the confidence of the patients, but their attenders also. So this went mouth on mouth to the various patients and attenders. They started coming, because during that COVID area, the outpatient number, the inpatient number, the surgeries, all these dwindled down. It came to almost 1/3 of what we used to have. So that is what, so because of this, again, the economy of this particular hospital came down. So anyhow, it was the blessings of the Swamiji as well as the management which took care of all these things. And apart from this, our emergency department took care of all the patients who came to the emergency, because at that time, we didn't know whether it is COVID positive or COVID negative. So I just like to give few examples wherein a patient about, I think, September 2nd week, a patient of 39-year-old came to the emergency department. He came with history of breathlessness, difficulty to breathe, and having chest pain. So within 95 minutes, this patient was investigated with a rapid test and then various other investigations. And instead of patient being thrombolized, he was taken for primary angioplasty. So within 95 minutes, this procedure was done and patient is able to walk around within 3 days. So this is the type of management that we are doing even for the non-COVID patients. So that means even the most of the patients who come to this emergency are taken care, not only for the COVID, but even the non-COVID patients also. Likewise, major surgeries like the laparoscopic surgeries, the neurosurgeries, and various other surgeries were also being conducted in the non-COVID area. And another requirement was regarding the blood. See, during this COVID era, we never had any blood donation camps. So most of the blood were given by the donors. So most difficult task was for the thalassemia patients. We have nearly about 60 to 70 thalassemia patients treated every month. For that, we are giving this blood for freely from our hospital. Even that was also taken care by our blood bank and the hospital. So emergency deliveries as well as the surgeries are being conducted regularly after screening the patient as per the protocol. So in total, what I want to say is that let us be positive, have thinking. Positive thinking is more than a just tagline. It changes the way we behave, and we firmly believe that when we are positive, it not only makes us better, but also makes those around me better. And it is always the actions that always speak louder than the words. Whatever I speak, it may not be worth, but the actions of what we do is going to speak more than what we say. Thank you. Thank you very much, sir.
Thank you, doctor, for you and your team for able to manage non-COVID patients effectively and efficiently. Thank you once again. I hand over the session to Mrs. Smita Shri.
Thank you, sir. Good afternoon, everyone. A vision without a strategy remains an illusion. Today, we have with us Dr. Nagendra Swami, SE, one such strategist who is a senior medical and hospital management executive of international stature, providing board-level participation in the development of strategy with proven expertise in delivery of key healthcare initiatives and quality meeting international standards. Sir is an adjunct faculty of JSS AHER. He is the founder chairman, Medisync Health Management Services Private Limited, Bangalore. Previously, he has held various administrative positions in the national and international organizations. One of such were Deputy Medical Superintendent of Manipal Hospital, Bangalore, Medical Director, Fortis Heart Institute, Chandigarh, India, Medical and Business Development Director, Middle East region, Amcare Labs International, US, in affiliation with Johns Hopkins Medical Lab, Dubai, UAE. Chief Operating Officer, Canadian Specialist Hospital, Dubai. In addition to his role as an advisor, he has held various administrative and strategic positions at Manipal Health Enterprise Private Limited during his course of career. To his credits, he has number of affiliations, fellowships, memberships with various national and international organizations. Now, I request Sir to deliver his insights about COVID-19 pandemic. Over to you, sir.
You have to unmute yourself, doctor.
Thank you for larger than reality and good introduction, but with pranams to Swamiji and with all the blessings of him, without much ado, I would like to little cover because everybody should, I am requesting pardon of all because I have jumped the queue because I have another seminar to attend at 2 p.m. So I'm taking out of turn, though I'm supposed to sum up the whole discussion today. But at the outset, I would like to say the session is going very well. Each one from various, starting from Dr. Dan and Dr. Our Dean, everybody is trying to put what all they have done over the things. The best that I liked was Dr. Sumana appreciating the housekeeping people. You see, it's very, very important in a team building exercise when we do such recognition of the people who are least expected to be recognized. I think that is a wonderful gesture. I sincerely appreciate it. It's a lesson for all of us to carry in ours. Now coming to the main issue, the topic that I have been requested by Dr. Dayanand to touch upon is the challenges faced by the private enterprises in the COVID-19 situation, especially being the president of the Karnataka All Private Hospitals Association. I call it as a principal coordinator. So I have been in the thick of this from the day one this issue started. First of all, like many of the speakers have already spoken, the unprecedented nature of the disease. Nobody had any clue previously what this disease will look like and what will be its implications. It's a dynamic process. We all learned as the disease progressed. That was the biggest challenge all of us faced. The unpreparedness of the both government and the private was clearly exposed, including the world's best healthcare facility countries were exposed, the lacuna in not preparedness for a pandemic like this. So I must appreciate in all the things that India has done reasonably well, considering the large population, diversity of the rural and urban, and also the number of the non-educated people that they are available in the society. I think we have done well. Lockdown was something very new to us. I don't think none of us in our lifetime had thought we will go through this kind of a situation at all in this. This has thrown open not only challenges, lot of learnings, the importance of life, importance of what we need to concentrate on. Initially, as you all know, government insisted they only will take care of the COVID patients and they will ask private only when it was required. In the initial discussion, we were told 15 days of advance notice will be given to the private before government requests. But unfortunately, as you know, nothing like that happened. One fine morning, suddenly it was announced, tomorrow onwards, private will get opened. We had no clue that it was coming, neither any discussion, because prior to that, I have been privy to the discussions with the government on behalf of the private sector, asking that we need time because we already have patients within our group. We cannot overnight start the thing. Unfortunately, due to the pressing things, they opened up without giving any warning to us. The most disastrous thing that what we thought was, even in spite of not analyzing who can treat COVID, who cannot treat COVID, we were pressed, including a 30-bedded hospital was asked to admit 50% of their beds. The logic, God only knows. So how can you have a 50% of the beds, not on economical reason? I'm not going to talk about economy at all here. I am talking about patient safety, infection control in a small setup where we can't have two different floors. And taking care, as Dr. Guruswamy said, taking care of non-COVID was equally important in the face of COVID. Suddenly, there was such a less importance of non-COVID that everybody was asked to pitch in. As you know, because of the unprecedented nature, ever-changing guidelines and SOP. Please understand, there is a central SOP, state being health being a state subject. Every central SOP need to be ratified by the government and allowed later, whether it be testing protocol or a treatment protocol. It was a daunting task to keep track of the everyday new guideline coming. We used to keep SOP 1, SOP 2, dated so much, SOP on treatment, SOP on testing. We have to run a secretariat only to take care of SOPs and circulate it among all the hospitals. Then came the biggest trouble, the staff, the tariff. There was the big confusion even today in the tariff. When they have written the, what do you call of package, none of us know. They have never declared what is clearly included, what is not included. For example, very, what do you call, motherhood statement. Anything included in the treatment and the tests included, routine tests and routine things. Nobody till today have defined what is a routine test and what is a routine treatment. Finally, what we did is, it is like this: when somebody doesn't give you guideline, you start your own guideline. The FANA released a guideline. What do we mean by routine? What is included in it? What is excluded in it? And ultimately, the SAST, which is supposed to give us the money, they responded to that guideline telling, no, you need to include this. That means at least whatever the FANA put in, that de facto has been now blessed by the SAST. They didn't want the bifurcation in the ICU setup. They said there is nothing like general ward ICU and a single ICU. Everybody should be at 25,000 a day. Then finally they accepted remdesivir was not a part of the package, nor the some high-end investigations like when you do CT thorax for which is very essential for the thing. They said that is not a part of thing. Such things are important for you to do the proper billing of the government patients and private also. Today, the pricing is available to everybody, though the government chief secretary's order very clearly says insurance is out of that. I have got a resolution by the general insurance of the India, which says in whichever state the government has announced a package for the insurance patient, the same package is available. This is the biggest fallacy of the thing. The insurance have made huge money by the premium. I want to just tell you, this year, for the first time in the history of India, health insurance premium collected has surpassed life insurance and also the vehicle insurance. Can you believe me? The premium they have collected, and they are now trying to latch on to the government packet to give the thing. Luckily, Supreme Court has given a direction in a case that all insurance cases, the patient, if he is insured for X percentage, you have to give him that money. That is a Supreme Court justice. You need to know why I am stressing on this is, if you don't bill properly, it becomes erroneously wrong perception by the media. Somebody covered the media fiasco that happened. Media, instead of creating awareness, they created a fear psychosis. It's more of the fear psychosis. And one wrong thing, you see, we have analyzed the bill of some 1,000 patients. The average bill of a patient is 1,14,000 for a COVID in a general ward. Ultimately, they showed some 14 lakhs bill, 18 lakhs bill, where a patient was on a ECMO, patient was on 52 days on ICU. They forgot the 999 cases. They took one case and made a big news about it. That also brings a lot of pressure on the private healthcare. And the second thing is, it is not the bed. Like somebody told, we can give the bed, we can give the ventilator. Where is the manpower? Where is the doctors? Where are the nurses? Where are the skilled manpower? We are stretching our manpower beyond what is necessity, but nobody is understanding. I can give a bed. Can I give the manpower overnight? That they are not understanding. So we need to stress upon them that infection control process requires us certain parameters to manage. More than anything, the quarantine of the staff after they have treated for X number of days the COVID patient, mandatorily they need to take a rest. We are unable to give in many times. After fighting thoroughly with the government, we were able to get the life insurance of 50 lakhs to every healthcare worker who died, whether it is private or government, if he was in a COVID duty. But the fallacy in that notice by the central government was only if you have been delegated by the government. The word you have been delegated by the government created an ambiguity. But luckily, when they gave a circular telling 50% of the beds has to be reserved, that is a delegation by the government. On that aspect, every departed warrior of the COVID today, whether a doctor or a nurse, is eligible to 50 lakhs insurance that is given by the central government. But unfortunately, it is not just the life. It is about the medical part of the thing. The people, I'm so proud of JSS, which has given all the staff who got infected very good medical cover. Their treatment, their thing, they covered to the best possible effort, which many of the other private were not willing to do. The smaller segments, we pushed everybody to take a COVID insurance to their staff. I think after having put them on duty, it becomes our obligation to help them out in that time. Lesser said about the lack of PPE qualitatively and quantitatively, and about the cost that went up phenomenally. As soon as there was a demand, we thought the cost will come down. Suddenly, the cost of drugs and cost of consumables went up. That also put it. Now we are all treating so many government patients, including JSS. The payment has been inordinately delayed. They promised us 15 days turnaround time for payment. Even after 4 months, only 16% of the bill has been cleared by the SAST. How is our, working capital? Where do we get the money to pay for the vendors? Where do we get the money to pay for the staff? And government, we also are giving some incentives to the people who are on the COVID duty. How do we do that? And many of the students have come forward to help in this. They should be acknowledged and taken care of. So timely payment is another issue that has come from all the people. And lack of importance and alternate arrangement for non-COVID is going to come and hit us very badly. So I appreciate that JSS has taken good steps to look at the non-COVID. Dead body challenges, all of you know, infectious dead body. Now the new guideline says you don't need to hold the dead body, hand over to the people after taking a sample. If it is a COVID, then you hand over to the people. All this points out to the only one thing. Please understand that poor public health, the poor public health is coming exposed like anything. The importance of public health is unsaid. I'm happy that a lot of importance is going to come on a public health now. That is what going to change the game. Poor understanding of the government officials who are from non-medical side of what is an infection, how it can be divided. They are simply thinking they want to meet a target number, they will say, go and do this. They want to meet a bed, they will do that. They are not understanding the governance challenges that comes out in the healthcare facility. Luckily, Indian government is pursuing something like IIS and IPS and IFS, Indian Medical Services. IMS is going to start soon. This pandemic has shown the need for a professional management in a healthcare and in the government sector. Soon an IMS will start. I'm very, very proud and happy JSS has started their course on the healthcare management well as an entity itself. It's an amazing this thing. We have to appreciate what all the things the JSS as a unit has done. Whether it is a vaccine trial, whether it is so many clinical trials that they are participating, adding yoga and breathing exercises into it. Shortly, the upcoming post-COVID sequelae is going to kill our country. A country which is going to be dragged by the post-COVID sequelae because hardly 10% of the patients have been admitted to the hospital. But the sequelae can remain in many people. I think soon there will be a fantastic facility all under one roof at JSS. The one thing that we missed in the whole journey was the reverse quarantine, which we should have practiced, protecting the what you call the aged people and the people with the comorbid situations. If we had paid little more attention on that, we would have achieved quite a bit more. The number today, yesterday itself, Karnataka has gone 10,000 plus and Bangalore city itself has got a 4,800 cases. You can imagine the numbers, how it is going up. As of now, as per the Johns Hopkins prediction, I think we will hit our peak maximum in November. We don't know when the vaccine will come a reality. The safety parameter has to come and the side effects thing. I think in that way, probably JSS is adding not just to India, it's going to add in their clinical trials to the world. With that, I would thank the organizers and Swamiji and the Pro-Chancellor and Dr. Dayanand for having given me this small 10 minutes time to share my experience, what I went through from the day one till today, still going through on fighting with agency, fighting with public, fighting with making sure doctors are protected. All of you know the healthcare workers have been badly infected and in whole India, 385 people have died, the doctors. As of yesterday, in Karnataka itself has got 92 deaths. I'm talking about doctors, which IMA has maintained a list. We don't know about the nurses. We don't know about other faculty in this. We need to be careful because in our anxiety to save and do our duty, we also should know we have a responsibility to our family. We should maintain the infection control policies set up by the organization very stringently. That is why I appreciated Ravi's talk, where they are doing daily 2 rounds to see HICC policy being sent. With that, I thank you all once again. Thanks.
Thank you so much, sir, for your insights on COVID-19 pandemic. Now I request Mr. Roshan to take over.
Hello everyone. An healthcare facility, in order to achieve any quality essence, needs a combination of clinical and managerial blend. Now I have such a person on board, Dr. Jairaj BS, who is professor and head of respiratory medicine department. Sir has a vast experience of 33 years as a doctor and also held many key positions in Mysore Medical College and also in our JSS hospital. Now I request Sir to enlighten us with his talk.
Hello. Hello.
We are able to hear you, Dr. Jairaj. Can you
Sir,
just make it?
thank you, sir. Good afternoon, everybody.
No, no.
And you can make it to the slide mode.
Slideshow.
Okay, slides.
Yeah, that's perfect.
Yes, correct.
That's perfect.
Is it okay, sir?
Yes, yes.
Yeah, perfect. Good.
Okay. So, good afternoon, everybody. Offering pranams to His Holiness Jagadguru Sri Desikandra Swamiji. At the outset, I thank Health System Management Studies for organizing this wonderful webinar. At the same time, I compliment and congratulate ICU team headed by Dr. Suma for doing a wonderful job. Not even getting bogged down, breakdown, relentlessly working for nearly 2-3 months. It's not an easy job to work in ICU because I know I have been managing ICU for a couple of years till the ICU team came to, intensivist came to Mysore. So I will be talking about clinical challenges and sustenance of life. Maybe I may exceed my time with the permission of the management. The statistics I thought would have been better if Suma would have presented what are the number of cases, type of cases admitted to ICU, how we manage them, what is the mortality, how many of them are came out of ventilator, how many of them shifted out, discharged. So I thought Suma was going to present before me. Because of some problem, I had to take over this. This is a continuation of the same talk. Actually, the ICU management is a multi-system team effort actually. So, we know this is a new disease and we have got limited treatment options, particularly whatever the drug we are using as of now, they are all repurposed drugs used for other viruses, for other diseases elsewhere. Because of some reports, some studies, they were found to be helpful. We are using the same drugs. Because of pandemic, no time to get the new drugs. We are using the same drugs, and each patient, though it's a COVID patient, they behave differently because of underlying comorbidities and also other type of immune system they have. Not only that, the timing of treatment, what treatment to begin, what time should be taken then and then on the moment. So there's no thing like waiting for some time, someday we're waiting for the investigation to come to treat this patient. This has been well managed by our ICU team. Okay, we have to appreciate them for that. So we look at the stage and character of this disease, the cases we get to the ICU are the cases who are moderately ill, moderate to severe illness, who are critically ill, and they are in severe respiratory failure, and then some people in septicemic shock with hypertension. So we concentrate mainly on the case of ICU, and if you look at the people, total number of cases, the percentage of cases, we do get to ICU around 15 to 20% of the total burden of the cases will be needing ICU care point of time. Among them, around 5 to 10%, they will be very critical. Around 5% may be on ventilator. So among these patients, mortality is very high, very huge, almost 40 to 62%. Almost I thought the Suma would have been presented our data also. Almost it's equal to this international mortality actually. Best of the best ICU centers where the mortality is even in UK, US around 40 to 62% in these critically ill patients. And I think we have the same mortality rate compared to these groups. Most of our patients, they succumb to mainly almost more than 50% they succumb to the respiratory failure, progressive involvement of the lung and worsening of ARDS and hypoxemia. And almost one-third of our patients, they succumb to both cardiac as well as respiratory problem, and another 5 to 7% maybe because of cardiac problems. So basically, the mortality is very high with elderly, obese patients, and people who have other comorbid diseases like diabetes, hypertension, IHD, and chronic respiratory diseases, and of course, people and lung transplant, cancer. So these are the patients where we do come across increased mortality. So the same thing is reflected in our ICU as well. Probably next talk, Suma highlights on that. So what we do in ICU basically, if you look at the pathophysiology, I'm not going to the details because Dr. Subhash Chandra has explained everything in detail. I just concentrate on 3 areas. So S receptor that are present everywhere in the endothelium and epithelium. That means throughout the different tissues and the organs of the body, especially huge thing in gut and the lungs, epithelium and airway. So ultimately, when the viral replicates inside, gets into the cells through S receptors, there will be epithelial injury and endothelial injury. So these are the 2 important aspects that we are concentrating. Because of this, there is what you call dysregulated inflammation. So a lot of inflammatory mediators are released, cytokines, and then various mediators are released. This will cause inflammation and damage to the various tissues and organs. And then there is endothelial damage causing endothelitis. This will actuate the procoagulation pathway. They resulted in hypercoagulopathy, and then what you call COVID coagulopathy. This results in thrombus. This is the important thing we have to we keep seeing in these patients. There will be microthrombus actually. Those are the microthrombus as well as macrothrombus. All this will result in the multi-organ failure. Okay. So this epithelial injury, endothelial injury, then the loss of alveolar capillary membrane integrity. So this exudation of fluid into that, edema fluid, and then this will cause ARDS. So basically what we are seeing in our ICU is patients coming with respiratory failure because of ARDS. There's the loss of alveolar capillary membrane integrity and there's edema here. So that will compromise the oxygenation. So we have to take care of the oxygenation. That is the respiratory failure because of ARDS. Number 2, coagulopathy, COVID coagulopathy, either because of microvascular occlusion or sometimes frank pulmonary embolism. Sometimes you keep seeing because of hypercoagulability state that is reflected in elevated D-dimer. This D-dimer is very, very important because this will gives us about the disease severity, activity, and predicts the risk of thrombosis and embolism in these patients on ventilator. And of course, it will help us in looking at the mortality in these patients. So basically, we will be concentrating in ICU on lung involvement, that is ARDS, and also other different organ involvement, ultimately resulting in multi-organ failure. So we have to look into the patient as a whole in ICU. So what we do, so we have a guidelines. We have a guideline from Ministry of Health and Family Welfare, ICMR. So what drugs to be used in which stage, and depending upon the trials that have been happened elsewhere. And also we have their own personal experience and also other management of ARDS over a period of few decades. So we make use of that personal experience as well as the guidelines available from our country and elsewhere and the literature available. We have to follow the management in ICU. So this is what you look at this clinical therapeutic staging proposal. When the patient comes to us, they'll comes to us with stage 2, that is 2B, when they already developed pneumonia, they already developed respiratory distress, they have got respiratory symptoms and hypoxia. It may vary depending upon the severity of the disease. Suddenly, some of these patients may suddenly deteriorate because of cytokine storm, because of increased cytokine release. So such cases we have to tackle immediately with immunomodulators. We'll come to that later. In few of the cases we manage with them. What happened and what is the, effect of that doing going for unconventional treatment and not tested treatment. Just I'll go through few slides later. So So this is the clinical therapeutic staging proposal. The moment the patient comes to us, probably if the patient develops hypoxia outside only, the Dr. Subhash and team would have taken care of that. They would have started remdesivir. This remdesivir may not be the game changer, but according to the ACT trial, this shortens the only recovery period. It's not going to alter any mortality benefit. But this is the only antiviral drug which is effective as far as today is concerned. But though it's not going to change the mortality, it's going to shorten the recovery time. Remdesivir usually we give it for 5 days. Some people even according to our guidelines, sometimes for few selected patients, if they are not responding, you still feel that there's still viremia, patient is still having ongoing viral application and other things. Some patients we can extend it to up to 10 days. So usually the dose required is 200 mg first day will give, then 100 mg followed by that infusion is only for 5 days. Then the next game changer is dexamethasone. That is proved beyond doubt in recovery trial. People given dexamethasone, there's definitely increase in mortality benefit. More than 8 to 9% actually. There's a mortality benefit when it is used in people, particularly if they have hypoxia, worsening respiratory failure, and we are thinking that they are still having cytokine release damage. Another thing you do it is oxygenation, very important. To keep the patient alive, you have to oxygenation. So there are different modalities that are available. Okay, and then I forgot to mention about the anticoagulants, heparin, very important it is. Because of COVID coagulopathy, most of this worsening of respiratory status may be because of microthrombus, or there may be a thrombus in the major vessels in the blood vessel, the pulmonary blood vessels, or they may be having unidentified pulmonary embolism. So all this will be taken care of by your heparin. So that we'll discuss anyway, the Suma might talk about that. So the game changer here is the oxygenation, maintaining the life of the patient and preventing them from developing severe hypoxemia. So we have got various oxygen delivery devices, starting with the simple nasal cannula, simple mask. So if it's not able to help them to maintain oxygenation, then you have to go for other modalities. Then particularly we prefer HFNC. So our director thankfully got many of these. So this has really revolutionized management of our COVID ICU. So this is preferred, in fact, over NIV. Okay, most of these patients tolerate well, will maintain hypoxemia, and in fact, barotrauma is less with this compared to your NIPV. So I'll tell you about something about barotrauma, which is more common in the ARDS related COVID. So then this has reduced dramatically the intubation rate and ICU mortality. Probably the Suma might touch upon that. So with the introduction of HFNC, our ICU mortality has come down, and also intubation rate has been reduced, because we keep discussing each and every case if there's any problem happening there and what sort of treatment to be given, what is the next approach, we'll keep discussing together. So this is very important thing. If the patient doesn't maintain oxygenation HFNC, then we'll go for NIV. That is the kind of non-invasive ventilation. Then this is what you call helmet interface. This will prevent actually aerosol generation and the problem to the spread of infection to our healthcare workers. If the patient can tolerate, we tried for one patient, probably patient could not tolerate that, maybe because of claustrophobia or whatever. So this is the best another interface for NIV, so that this will prevent aerosol generation and spread of infection to our healthcare workers. Then what we do routinely is what you call proning. You'll make the patient lie down on their belly. That is what you call awake proning. Sometimes patients, even if they are not on ventilator, you put them on the belly, that itself will increase the oxygenation. This will be done for all patients, irrespective of whether they are severe, whatever it is. When there's hypoxia, the oxygen requirement is very high, you put them on their belly. So there was a Prosever trial done, almost is published in 2013 in NECM. That means for the past 1 decade, we have been following this for all patients of ARDS. Same thing is being followed, which is helping a lot for these patients, probably postponing intubation. Sometimes these people recover with other modalities of treatment without intubation as well. So I'm not going to the details about that. Another important thing is the management of ventilator part. So this barotrauma is very common in, I'll give the example of the cases later after some time. So barotrauma is the common thing which we see in COVID ARDS. So otherwise also barotrauma is common in ARDS. So that's why what we have got ARDS net protocol. That is there. That is standard we follow for all the patients with ARDS. That is what called lung protective ventilation, where we try to ventilate the patient with low tidal volume as much as possible, and also maintaining tidal volume and respiratory, adjusting the plateau pressure of less than 30, and then adjusting PEEP and FiO2. PEEP and plateau pressure is very important for judge about your barotrauma. So PEEP and FiO2, we adjust each other so that we maintain adequate oxygenation. Neither hyperoxygenate or we drive the patient to hypoxic level. So this is what you call lung protective ventilation. Sometimes you have to call hypercapnic ventilation. Sometimes you are allowing little CO2 to retention, acceptable pH, is reducing the rate and tidal volume. We just try to avoid rupture of the lung, what you call lung barotrauma, by going for lung protective ventilation, sometimes hypercapnic, permissive hypercapnic ventilation. So this is all what is happening inside the ICU. Next, there is some confusion about the timing of intubation. There have been a lot of comments. Oh, that patient died because we intubated him early. We could have waited on for some time with HFNC or NIV. That is not the case. If the patient requires intubation, we have to intubate because there is no other option, because we have exhausted all the option of maintaining oxygenation. Okay, so patient is having tachypnea, almost with maximum non-ventilated support, we are not able to maintain adequate oxygenation, and he is having very high respiratory. That is will worsen the ARDS. That is what we call patient self-induced lung injury because of shear forces, because fluctuation, lot of fluctuation in the intrathoracic pressure, that it will worsen the ARDS. That's why when the patient is very sick and is not able to breathe, there's already a lot of distress and going in for respiratory muscle fatigue, and CO2 is building up, is retaining carbon dioxide. That is the time you have to intubate. Whether it's early or late, that's not the matter. The matter is we are not able to maintain oxygenation with available non-ventilated parameters, and we need to improve the oxygenation. We have to ventilate, otherwise we are losing the patient. So if you do it early, if you do it late, again it's a matter of decision actually, depending upon the individual patient. There is no cookbook approach. So one size does not fit all. We have to individual, depending upon the that individual patient we are managing. But one unique, of course, they think about L type and H type of phenotype in ARDS of COVID. That may not be the case. This may be just the natural course of the disease. Initially, if you see the ARDS patient in COVID, you do expect good complaints, maybe low EQ mismatch, maybe the early part of the ARDS. That's why the complaints may be high. And the later part, again, the complaints may be low. You need to ventilate them with high PEEP, high pressure. So this may be just a progression of the disease. So I don't think there is any L type and H type, which there is a misconception of what I feel. But what is important is, with minimal lung involvement, many of these patients may be severely hypoxic. This is one unique thing we have observed in COVID ARDS patients. This is expected because COVID is a multi-system disease. The virus involves different organs, including the brain, respiratory center. So that may, it can damage, it can affect the respiratory center also. It can affect the respiratory muscles. So they have that. So there's a muscular part, bellow part, this controller part, as well as a part in the lung, damage in the lung. All this will add to the hypoxia. So we do not just look into the only what's happening inside the lung, and also the vascular part. That is coagulopathy, COVID coagulopathy. So there may be obstruction in the capillaries, maybe small vessels. This will add to the hypoxia. That's why though the lung look normal, these patients will have severe hypoxia. So for these patients, we have to give a lot of options. So increase the coagulants, anticoagulants, and then improve the respiratory muscle functions. And this will take us. This might prevent little postpone or pull them out of going into the ventilator. So this is what I want to stress on that. This is the only peculiarity which we see in this patient. And then there have been case series, where these people developing pneumothorax, subcutaneous emphysema. It has happened. Not only on the ventilator, even if the patient is on supplemental oxygen and FNAC, there have been the reports that these people have developed subcutaneous emphysema and barotrauma. Okay, this is known actually. Maybe this is expected because there's a lot of inflammation going on, then injury to the lung, they may develop damage to the lung. So with little pressure changes, we expect that they do develop pneumothorax. So this again case series, this shows that there was no correlation between the rate of barotrauma and the specific ventilator setting. It's not related to either ventilator setting, nothing else. So there is an inherent problem happening in the lung because of COVID. That's why patient will develop pneumothorax. This is one of the excess of the patient just admitted 3 days ago to the ward. He was admitted only for the respiratory distress and breathing difficulty. So the X-ray showed, clinical findings showed that he had pneumothorax. We had to put the tube immediately. Post tube, there is complete expansion of the lung. Patient is all right. This person repeatedly he denied any possibility of smoking, whatever it is. He never had any other problems, and he did not disclose that he was COVID positive just few days back, just 1 week ago. So he didn't tell us that actually. But later, the third party came and told us he was under home quarantine because of COVID positivity of just 5 to 6 days duration. So that means this man, normal person, non-smoker, 34-year-old, developing pneumothorax. That means there is some inherent problem happening in the lung. So this is the challenge to the intensivists there. So whatever the positive pressure we use for ventilation, there is going to worsen the paratrauma. So this is well taken care of by our intensivist. We have been discussing about this problem also. Then another problem is about the sudden deterioration of the patient on ventilator. Either this can happen because of worsening of the disease, or cytokine storm because of excessive release of cytokines, and also because of pulmonary thromboembolism. It is very common. Any ICU ventilated patient, it is common. It is almost twice common in COVID patient because of coagulopathy, COVID coagulopathy. So there have been a lot of literature, a lot of studies on this. So very, very important. So the D level, roughly D dimer level gives some clue. Very high D dimer level, mortality is going to be high, progress of the disease is high, risk of thrombosis is also very high. So we have to tackle this. Sometimes you have to give full dose of heparin or anticoagulants. Sometimes we have gone on giving what you call thrombolytic therapy without evidence of pulmonary embolism. Usually there are indications for thrombolytics in a ICU scenario. There are case reports, case series where people, if the patient on ventilator deteriorating, not able to do anything, except ECMO and lung transplant, some of these patients can be pulled out. They came out of ventilator, went home because of thrombolysis, what you call low dose thrombolysis for these people. Because we don't know, even without demonstrated or confirmed thrombus in the lung or pulmonary artery, these people have, this has helped them actually. We will not go into the details. Even we have tried for a couple of patients in our setup, thrombolysis. Even our one of the staff, his life is saved maybe because of low dose thrombolysis. We have given RTPA, that is recombinant tissue plasminogen activator, maybe around 25 to 30 milligram infusion was given, I think. That's a low dose, 25 to 50. So that has helped him come out of this acute problem that I think Dr. Suma will highlight that, and I'm sure. And then convalescent plasma. This plasma again is like a flash in the pan. It came and went. So whatever the studies available, world literature, it has any good opinion about. Even the recently completed PASSIT trial ICMR, even that doesn't say that there is any mortality benefit. Even the people who had mild to moderate disease, they have progressed even with plasma therapy. So as of now, we are in again we don't know what exactly the status of this, but still the guidelines says that in a patient who is moderate COVID deteriorating, we can give a still trial with convalescent plasma. Maybe if it's given early, it might help, because most of the studies, they have given the convalescent plasma little later actually. That time may not help that. Already virus is there, it has gone into the cells, caused all the inflammation. So at this stage, this convalescent plasma may not help. So that may be the reason why most of the studies show the negative reports. So again, this is the FDA UAE guidelines. What it says that there is insufficient data to recommend either or against the use of convalescent plasma in a COVID ICU treatment. So convalescent plasma should not be considered standard of care in the treatment of COVID. But our Indian government, Minister of Health and Family Affairs, still advocate in patients who are deteriorating, moderate cases, still we can try convalescent plasma. But we have used convalescent plasma for probably 1 month ago. After that, I don't think we have used any plasma for any patient. And the statistics that Dr. Suma will tell us. And again, with all these problems, we are not able to maintain these patients on ventilator. ultimate thing is we have to somehow put in the oxygen into the blood. So that is the what you call ECMO, extracorporeal membrane oxygenation. So if the lungs are damaged, cardiac is okay. So venous ECMO is sufficient. If both there's a cardiac involvement, myocarditis because of COVID, there's a severe cardiac dysfunction, then you have to go for veno-arterial ECMO. So this is available in some of the Bangalore centers. It's a boon actually. Some of these patients might require it one point of time, and some of have come out of ventilator also. Some have undergone lung transplant even in nearby state. So they have, that patient is doing well actually after ECMO lung transplant. So this is the modality which we are lacking in Mysore city. Some patients. Okay, then this will not go with acute problem. So this is going to, like Vetala, is going to go with us only. Like SARS and MERS, we keep seeing patients with post-COVID pulmonary fibrosis. So the very dreaded complication actually. So some people land upon even progressive worsening of lung fibrosis and hypoxia, requiring lung transplantation because we don't have effective treatment to halt the fibrosis. So what, particularly for these conditions, so we have got for IPF, there's some treatment available, though it's not going to alter the course of the disease. So this is the dreaded complication we are expecting and waiting for it. And couple of our patients also, we have come out of ICU, and even without mild disease, we are noticing them that they are coming back again after 3 months with evidence of respiratory distress and the exercise intolerance, developing fibrosis. So we need to tackle this. A time might come, then we have problem with post-COVID fibrosis problems. Okay. So this is what happens. This is just ground glass opacity, a patient after 3 weeks coming back with fibrosis, which is progressing, patient is symptomatic. So we will be oxygen dependent. Sometimes if we don't know how it's going to progress, after some we don't know, this is a new disease, and after sometimes it may progress further and he may land up in further progresses and then lung transplant. So we're waiting and watching for this, what's going to unfold. These are the modalities of drugs that are available for fibrosis. For others, for IPF we have got say perfenidone, and for a couple of these patients we have used perfenidone also here. Immediately after getting discharged from the hospital, we start them on perfenidone. Then we'll ask them to come for follow-up regularly, and we are just following up what's going to happen for them. This is what post-COVID follow-up. They are going to have going to see persistent cardiorespiratory problem, musculoskeletal problem, neuropsychiatric problem. So we need to have a very good post-COVID rehab centers, and we don't know what problem we are going to face a few months down the line, down the road. So this is the actually the how we follow up these patients. This guy, these things are given there, but again we have to modify according to our patients. So we are keep a watch on that about the post COVID problems. And then very important thing, we want to achieve a TB free India by 2025, 1 decade earlier than the elsewhere. Is it possible now? Because if you look at that, tuberculosis and COVID-19 infections are the disease involving the lung. Very important. And we are shifting our gear away from the managing tuberculosis nowadays. See, the prevalence of tuberculosis in a COVID is almost 5%. It's not a simple this one. And notification rate, we wanted 100% notification. In Karnataka, we had 85% notification till the onset of this disease, till January, March. But January to June, the notification has drastically has fallen down to 26%. Imagine, it has gone to the national program era. So we don't know what is going to what is waiting for us after the COVID about the tuberculosis. So for tuberculosis with untreated, the case fatality rate is 10%. For COVID, case fatality less than 3%. So that means you are missing even major disease, but only concentrating on only the COVID. So that's why the National Tuberculosis Elimination Program has come up with the new guidelines now. Then all patients admitted with COVID, in the ICU or wherever, they have to be screened for tuberculosis. But with some catch, which we have discussed with our NTE team and our state and other things, how to go about it. Okay, this is a very important thing. We are not supposed to just keep quiet with that. Anyway, so there is a lot of things we have to awaiting for what is going to be unfolding as far as disease is concerned, acute problem, chronic problem. Then I think I'll end this talk. I don't know, probably I must have exceeded a lot of time. I didn't actually observe the time.
It was a
Sorry
very
for that.
passionate speech,
Sorry,
Doctor.
sorry for that. Sorry for that. I just
No,
I
it was
just
a very
wanted everybody
passionate talk, and
yes, I thought.
I think we should listen to you for one full hour sometime. I think.
I'm very sorry for that.
No.
Yes, sir. We can
I
have
mean, it was
a
so much.
separate presentation.
Thank you.
We can have a separate presentation in academic society or through the other forum.
No, I think we should listen to his talk fully.
Yeah. Yes,
with
sir.
complete input. I think it will be a good. I mean, I was learning so many things sitting here.
Thank you, sir.
Thank you, Professor Jairaj. It was a wonderful talk, a passionate talk, I would say. You are really speaking from experience and heart. I mean, that's very important.
Thank you, sir.
You are a one-man army. I always tell that Professor Jairaj, once he suits boots and goes in like Rambo, he finishes the job and comes out.
I started first ICU in my series actually, way back in 91.
Okay. Now I request Dr. Sumalata to deliver her talk. Ma'am, if you are ready, you can take over, ma'am.
Good afternoon, everyone. I'll not hold you all for long.
Yeah, you can go ahead, doctor. It's fine, please.
I'll not hold you all for long. I know all your stomachs are churning. So when it was in April, I think we were asked to start a closed ICU model. We are at that time only 3 intensivists. So first thing I did was call up my ex-HOD and I literally brought him out of his retirement through the number of phone calls I have called him, I think. So he told me that, you need to prepare properly because this is not going to end soon. You are going to be in front of a tsunami in the next 3 months. So we had a meeting with medicine, anesthesia, and pulmonology, and we decided less than 20 patients, we intensivists will look after. But the moment the patients increased to more than 20 patients, we needed help. So although its establishment of ICU is not just clinical work, you should start having your administrative processes in place so that it improves patient outcome. Our goal was no matter what the patient is, whether he's a suspect, he's positive, he should receive the same kind of care that we give in non-COVID ICU. So that was our goal. So with this goal, we decided to have a model where when you have more than 20 patients, you need to have amalgamation of all 3 branches, medicine, anesthesia, and pulmonology. So these 3 form the core of the core team, and we decide as the consultant how to take care of these patients. But we need backbone. Our backbone is mainly our anesthesia postgraduates and our nursing. Really hats off to their dedication because without them, we could not have achieved anything like this. And the preparation for all of this started in April itself. There has been one meeting with the anesthesia department and we set it up ourselves as to how to go about things. And I'm really thankful to Dr. Gurdat sir for all of this. Of course, in the night, the anesthesia PGs are exhausted. They can't do 12-hour shift. We have pulmonology and medicine postgraduates also contributing. So what happens if our core team members are positive and we are short-staffed? We came up with the idea of using super specialty postgraduates as consultants because they are post-MD medicine. Those who are from medical branch, they act as consultant. And finally, the core team, if depleted, is replenished. That's what is happening. 3 of the four intensivists are now out due to medical reasons, 2 being COVID positive. Now it is being run by the help of super specialty PGs and pulmonologists and anesthesiologists. We even had cardiac anesthetists coming in and pitching things. So what we have done so far, we have gone from 8-bedded closed ICU to 30-bedded closed ICU, currently running 18 ventilators and 10 HFNOs. The crown jewel in our tiara is HFNO, I can say, because that's the one that has, prevented mortality. In fact, any patient, single organ, only ARDS, we can pull that patient off through HFNO alone. And the beauty of it is no secondary infections. Hospital-acquired infection or VAP is not seen in HFNO. So that's where we have an advantage. I really thank the administration because in the time of financial crisis, they gave us 10 HFNOs when we asked for 10, they gave us full 10. So really thankful for the vision of administration here. And so far, we have treated 585 SARI cases and approximately 300 confirmed COVID patients. Bottom line is this: no nosocomial acquisition of COVID disease in ICU so far. None of our staff nurses or colleagues have acquired COVID disease in ICU. This is because of HICC. The credit should go to HICC. We have a proper protocol of donning, doffing. After that, go home, have your shower, mingle with family. That's how we have been doing the last 6 months, and none of us have got COVID through ICU. It is because of our social life outside of the ICU. So we have protocolized care here. References are kept to minimum except for nephrology. They are indispensable part of our system. And I would like to thank Manjunath sir because Shetty sir has been really helpful in the time of crisis. Before I go to management, I asked him for any advice. There was a time when we were really short-staffed. Nephro PG was positive. They are running everywhere. There are too many COVID positive patients. Yet they don't. He said, "I'll send you my postgraduate Suma, don't worry." So this was the kind of support I've been getting here. So I'm really thankful for that. On the clinical front, Jairaj sir has covered everything. I discussed all the complicated cases with him. He's been like, you need not worry what time I call him. That has been the kind of support I'm getting through him. We all of us, all the team members are really thankful. This is what we have done so far. Only 5 patients we have tried low-dose thrombolytics, and as sir described, one of our own staff has been successfully thrombolized and we could pull him out of ICU after 20 days. CRRT we have tried, cytosol we have tried but failed. We have stopped using IL-6 inhibitors because of the secondary infections that we are seeing in ICU. This is the summary statistics so far. Initially, we had only 32 admissions per month in the month of April and May. We received only SARI cases then. Those were all suspects, not a single positive in April and May. We were running it in SICU, which was only 8 bed. Then the cases started increasing. We moved to Burns ICU and RICU. And that time, still we hadn't got any positive case, but mortality slowly started increasing. And it was in July that we got the first case. See the number of cases that has been increasing. The first graph is the total number of admissions in ICU. Whereas the second one is shift out. The third one is death. So there has been constant increase in the number of cases, constant increase in the shift out, and similarly, mortality has come down. So apart from this, there is an entirely different angle to the disease, that is ensuring patient and family satisfaction. Even though they are in ICU, they are COVID patients. Remember, they are humans. They are separated from their family. In the time of their worst sickness in their life, then they are unable to meet their own family members. So to ensure patient and family satisfaction, we have introduced all these measures, and we have aggressively taken up palliative care and non-escalation of therapy also for those who cannot, we know that are not going to save. So that is one thing. It has been gut-wrenching to see family members separated, unable to say a final goodbye, unable to give a hug or a kiss when you know your own loved members is dying. So this is, I think, has taken a toll on all of us who are taking care of the patients also. This is the mortality so far. Initially, April, May, we had standard ICU mortality. The standard ICU mortality varies anywhere between 10 to 20%. We have been adjusted to it, accustomed to it. We know that, okay, we have given the best possible care. This is the ICU mortality. But see the mortality in July, August, September. It varies from 30 to 40%. Basically, every third patient you are seeing in ICU is going to die. So that is it is very difficult pill for all of us to swallow. But luckily, the mortality is slowly coming down because the number of patients we are receiving is mainly from our own wards and zones who are well treated. So rather than flu clinic where they come in very bad shape, I think that is the reason why the mortality has been reduced. So let's see, where do we stand compared to other institutes? St. John's, Tata, CMC Vellore all have DM program. The institutes are being run by DM, post-DM consultants, and the residents are post-MD and MD anesthesia and MD medicine. Look at their mortality. It is ranging from 20% to 40%. So in that way, I think we are on par with them. The only thing is this whole data is meaningless without an Apache score. So I'll just leave it to judges. This is our brain when we are on duty. You'll have to arrange beds. You'll have to see the vitals. You have to talk to the nurses, motivate them, see there is no attrition, resuscitate, palliate, talk to pulmo, make sure the anesthesia PGs are not demotivated, thrombolize, ABG, follow-up, dialysis, beds. This has definitely taken a huge toll, and all of us, the core team members, I'm really actually proud of all the whole team, because all of us are very young, less than 35 to 40 years max. All of us have young kids at home. And with that also we come to work, we forget we forget our family, and we're giving our 100%. And we have a schedule 24/7. We are on call for a week, and then there is a rest week. We rest, we rejuvenate, we enjoy with our family, and then come back. So the future goals are only this: quality improvement initiative. There is a lot needs to be done to improve our ICUs. We know that psychological safety of the team members, like junior most member of the team, should be able to voice his medical opinion without being scared of the senior most member of the team. So this is a work culture that we want in ICU. We are trying to work for that. Antibiogram in ICU, very basic. We don't have right now. We are working on collection of data. We are also working with management for safe intra-hospital transport. We need a cart. We are designing that with the chief engineer and our biomedical staff to have, safe modality of shifting to CT, MRI. Most importantly, addressing nursing attrition. Our nurses have been fantastic. There was a time in ICU when, I had only one PG, 13 patient, totally overwhelmed with the work. But one of our senior nurse comes and tells, ma'am, we can't see you struggling so much. Can I help you in clinical examination? Just teach me what to do. Teach me how to examine the patient, what I'm supposed to do. This has been our nursing attitude, and I'm really thankful for what they have done so far. What has taken a backseat is research work. So we are short of hands, so we are not able to do research work, collect data. See, whatever said and done, whether we are doing a scientific way, our treatment is scientific or not, we can get the result only through research work, publish, find out where we have gone wrong. This we are unable to do. We have started to collect data. Let's see where we head. We need to devise a better mechanism to address burnout. The future plan is to involve actively with psychiatry and get some help, counseling for those who are burnt out. And of course, academic activity, because I think another 1 year, if we continue like this, we'll forget about non-COVID diseases. We'll know only about COVID. So this is what we plan to do. So in the end, it is all teamwork. Whoever takes out a single person's name for the success of closed ICU, I would like to tell them that please, when you say one person's name, it is included everyone, our 4 intensivists, Dr. Akshay, Dr. Chaitra, Dr. Jeevan, 2 pulmonologists, Dr. Nandakishore, Dr. Lokesh, entire team of anesthesia. They are working in OT and they are working in ICU. Our nurses, our postgraduates, fantastic workforce, anesthesia, pulmonology and medicine in the night, and our nurses. So the credit should go to the entire team and not to one person. Thank you for the opportunity.
Thank you, Suma ma'am. It was a wonderful thoughts what you shared. So it gave us a lot of information on what goes on in the hospital. Thank you. Now moving on. Service organizations requires emerging leaders to push it towards excellence. I'm happy to introduce such an emerging leader in our organization, Dr. Naveen N. Sir is a renowned orthopedic doctor and also Deputy Medical Superintendent of JSS Hospital. Now I request Dr. Naveen to deliver his talk on stress management. Over to you, sir.
Meanwhile, he starts presentation. I think I request all the speakers who can just witness this chat box. There are specific directed questions which you can answer them in the chat box because we may not have time for interaction. So all the speakers are requested to visit the chat box, question answer box, and answer them specifically, whichever is directed to a particular speaker.
Reminiscing the noble works of Jagadguru Sri Shivaratri Rajendra Mahaswamiji and offering my humble pranams to Jagadguru Sri Shivaratri Deshikendra Mahaswamiji, I wish everyone a very good afternoon.
Your slides are not yet opened, I think.
Anything that poses a real or perceived.
You click on that image down, yeah. Open that slide. Yeah, now it's visible. Yes.
Yes. Anything that poses a real or perceived challenge or threat to a person's well-being can cause stress. However, stress can become a chronic condition if we don't take steps to manage it. Stress is simply caused by something around us that disrupts our everyday equilibrium. We all need to practice helpful techniques to be able to manage stress with ease. The way each of us handle stress is different, and all people have different personal stress management plans. Assertiveness is an important factor in communication, which plays a key role in avoiding tense situations. One must stand up confidently and address the issues with a calm mind. Inefficiency occurs when we lose our ability to manage the situation. Fear is the imagination of bad events, whether or not they will truly happen. By reducing anxiety, we can control stress. Sometimes finding the time to do too many things can be stressful. The consequences, as you can see, lead to irritability, sudden outbursts of anger, social withdrawal. So reducing stress. At first, we need to recognize the source of our stress, holding positive thoughts, surrounding ourselves with inspiring people, which can elevate our mood and reduce the stress. An interesting hobby can also give us relaxation and stop the cognitive effects of stress on our body. Some people resort to alcohol abuse for temporary relief. Those who drink to drown their stress must be told the stress knows how to swim. How I used to manage stress. When the pandemic COVID-19 broke out, I was appointed as a nodal officer of JSS Hospital. And being a Corona warrior, I was expected to do a lot of multitasking. Initially, the job was exciting. As months passed, with the number of patients increasing by the hour, the responsibility on my shoulders grew exponentially. The job which I could manage alone now demanded the assistance of more people. So we built a strong team, and we all were successful in handling stress and managing work at the same time. As COVID-19 cases escalated near the flu, a number of people started thronging to get themselves tested. They were not maintaining social distancing, breaking the line, shouting and fighting. I tried to advise them politely in the beginning. When it didn't work, I had to scare them that they would get infected. Later, I had to finally resort to warn them. Some anxious attenders of inpatients used to call frantically, inquiring about the status of the patients. Instead of being judgmental, I had to answer them politely by being supportive. Handing over COVID-19 positive dead bodies was another major issue. The attenders of patients used to be grieving, emotionally disturbed, and crowding near the mortuary. I had to maintain my composure, express compassion, and extend comforting words to console them. Proper guidance was given to them on how the Mysore City Corporation would take up the task of cremating the dead bodies with due respect. There was a time when I was flooded with phone calls that I had to change my mobile ringtone to a more soothing one to avoid irritability. At times, I prefer to remain silent to calm myself down. I picked up a few healthy habits like walking, gardening, listening to music, and eating a balanced diet. A sound body is where a sound mind is. The pandemic fear and social dilemma had to be kept away from impacting both physical as well as psychological well-being. Dear all, on this wondrous occasion of Gandhiji's and Shastriji's Jayanti, I would like to quote their words respectively. The best way to find yourself is to lose yourself in the service of others. We can win respect in the world only if we are strong internally. Wishing you all a stress-free life. I thank you for your patient hearing. Thank you, sir.
Thank you, sir, for such in-depth ideas. I hope we will adapt the same strategies what you have taught us, sir. Now I hand over the session to Mr. Harshit for the further sessions. Thank you all. Mommy. Hey, Harshit. Harshit, unmute.
Oh, okay. It's my pleasure to introduce Dr. T.S.S. Rao, Professor, Department of Psychiatry, JSS Medical College. Now, I'd like to hand over the session to Dr. T.S.S. Rao, sir. Over to you, sir, for your speech.
Good afternoon, everybody. My pranams to Puja Swamiji, respects to seniors, and good afternoon to friends. Already Dr. Suma and Naveen have given many of the aspects what we actually talk about mental health issues. At the outset, let me tell that I am very proud. Even during the severe lockdown period, our department has worked, and the great help that was available to me from the HOD and all the staff members, I need to acknowledge at this particular point. I am also well aware that as a psychiatrist, I should be aware of mental health issues of all the people who are listening to this particular. WHO recognized that these mental health issues are extremely important in the beginning itself. And we had come out with a very specific article on, though we are talking about death and a lot many other such things, the massive psychosocial impact is going to be one of the major issues in the coming days. And I have two hats to do, one as a departmental professor of psychiatry there, and as a general secretary for Indian Psychiatric Society. We came out with the guidelines how actually the psychiatrist should work it out. And we provided the free consultation services by telepsychiatry to the people who need. We have collaborated with Indian Medical Association, ICMR, and along with that, we gave a position statement how actually this particular aspect need to be dealt with as far as the various range of psychological issues are concerned. The psychological issues of general population are different from the vulnerable groups, whether you're talking about children or old people, women, those with comorbidities, and mentally ill. In fact, they already have some problems and exacerbation of some of these type of things. And those people who started working from home and issues related to that. Over and above, in fact, when we talk to the people who have COVID-19 and those with no symptoms to mild symptoms and those with serious symptoms, their relatives, issues are quite different. Frontline warriors, though they are putting up so much of effort, they are also going through a range of psychological issues. I just want to mention that we have done almost around 14 to 15 publications related to this, online survey related to the extent of psychiatric problem available, and what we could recognize around 28 to 29% increase in anxiety, depression, and around 40% of the people had anxiety, depression who had responded to this. We did studies related to the sleep and lot many other aspects, and the data is available in the public domain. Dr. Naveen was talking about stress. I'm going to talk about anxiety, depression, and all like. People may be actually wondering how precisely to understand, but as a joke, because already it is late to keep you awake, Stress is one of the jokingly, I can put it directly, when your wife is pregnant, it is slightly more. Anxiety is when your girlfriend is pregnant. This is little more than that actually. Panic when both your girlfriend and wife are pregnant. That means you're really upset and really troublesome. Tragedy or depression when none of these things are because of you. That's the point. That is the worst possible scenario. So I have tried to give a brief idea of what actually all these terminologies carry. But important point is actually in psychiatry, many of the disorders, depending upon what is the dominant symptomatology, we try to classify, and there is a significant range of increase in majority of the minor psychiatric disorders, personality disorders, more specifically those who had obsessive compulsive symptoms and things like that. Very, very significant increase. Depression is one of the key component one should remember in almost all category of people, and increasing suicide and related things actually people have very well documented. Long-term chronic stress bound to produce a range of difficulty. Each and every system is likely to get affected, and in this particular time of COVID, we should positively remember, in fact, not only the lungs, each and every organ in our body is actually likely to be affected one or other ways. Alcohol intake has increased, other drug usage has increased significantly, and very many newer dependence and other related things, like starting from the gambling to dependence to the TV, mobile, and things like that. We have to understand the type of difficulty when parents come and talk about the children unable to be managed, because these are the things which actually they have no control at all, and this has become problematic. A range of metabolic problems have cropped up mainly because we are not exercising properly, we are eating too much, or possibly, in fact, many of the activities like couch potatoes adding to the things like that. I can't just stop talking about sex, because this is one of the other area where a lot of problems have cropped up, and you name the type of difficulty, it is there. Intimacy. There was a time when we were reading in the TV, in fact, seeing in the TV and reading in the newspapers and things like that, a significant improvement in the relationship. I never used to have my husband all along with me or my wife together and all of that. We are very happy. But then we realized around 70% of the people were complaining because I had to stay with my wife or she has to stay with me, and all my nuances related to the problems were apparent. Increasing divorce, increasing sexual problems were extremely well documented, and we have at least about nearly around 4 papers related to that. Different things, actually the things have gone on. Ultimately, what I can say, the psychological issues are extremely important, is as important as the physical health related issues. What we basically talk about to increase our immunity itself, to reduce stress, maybe the exercise, good diet, good sleep, and many of these yoga and other related meditation related techniques, and ultimately when necessary, taking help of the doctors is extremely important, and one should not hesitate in this particular area. One of the major advice what we almost always tell people is actually don't get carried away by what all you see in the TV or WhatsApp. In fact, so much of things is actually nonsense there. Be careful. And one advertisement, the government itself, ये जमाना डरने का नहीं है, हौसला रखने का है. What actually he talks about is extremely important. And with this message, I'll say that we are all available anytime for anybody. In fact, this is the message you have conveyed to each and everyone. With this, I thank each and everyone who provided me this opportunity to speak to you. Mental health is everybody's business. We all should take care of it. Thank you very, very much.
Thank you very much, sir, for enlightening us on mental health. Now, I would like to introduce Mr. Lokesh, sir, Administrative Officer, JSS Hospital, to kindly deliver his speech.
Focus ಆಗಿದೆ ನಿಮಗೆ, ಅದು ಫೋಕಸ್ ಮಾಡಬೇಕಪ್ಪ. ಫೋಕಸ್ ಮಾಡಿ.
For 5 minutes and minutes.
Good. Short and sweet. ನನಗೆ ಗೊತ್ತಿಲ್ಲ.
You wanted to drive others to mental issues.
Thank you. Thank you, sir. Now I request Mr. Lokesh sir to deliver his speech. Hello. Thank you, sir.
Focus.
Good afternoon, all. Focus. With the blessings of His Holiness, today my topic is management.
Sir, kindly unmute your audio, sir. Sir, kindly unmute your audio, sir.
Good afternoon, all. With the blessings of His Holiness, today my topic is management of resources and making them available. So, as all you know, that the resources we have classified as manpower, materials, and money. So today I'm skipping the topic money. So let's go with the manpower. So you know that human resources is the valuable resources. So highest priority was given for staff health and awareness. So there was a continuous monitoring and practice on social distance, mask wearing, and sanitization. So work hours was cut down to minimize the exposure of staff. And there was a provision of alternative day work allotment to bring down the individual stress. And to bring the quality and better treatment, we additionally recruited 100 nurses to maintain the peak of the pandemic. So, and additional staff were pulled out from the sister concern. From the nursing colleges, we hired some of the experienced staff. So thanks to Vidyapita for providing all these facilities. So once the nurses are on the board, the challenge was to provide the accommodation. So that too within the campus with all the facilities, keeping in the mind was a great challenge, and we have done it. One more challenge to administration was identification of sick staff and diagnose them and isolate them to avoid the spread among the groups. All outsourced staff like housekeeping, security, canteen staff were provided with free in-house accommodation with food, as it was a lockdown period and there was no transportation. So we accommodated them all in-house. Even outsourced staff were allowed to admit irrespective of their health schemes. So they had ESI and other schemes, and they used to go to ESI hospital and there was no beds. So suddenly, without any thought of secondary thought, we admitted them immediately and we responded for the life saving. So mental stress and psychological support classes were conducted by in-house psychiatrists. Next slide, please. Doctors, nursing staff, and cleaning staff were recognized and rewarded for their contribution as COVID warriors. Staff on front end communicating to patients were provided with all necessary protective equipments. All the PPE shield were given, and barriers were created to avoid easy access by the patients. Back-end staffs were provided laptops and dongles who were eagerly to work for the month-end salary or whatever. So we provided an opportunity to work from home. Digital tabs were provided for the video counseling of patients, and video communication between visiting consultants and staff working in COVID areas were provided. Daily immunity booster health drinks were provided to make the staff available throughout the day. So next resources is the material management. So it was a great real challenge during the peak of the pandemic. So I would really honor our honorable director for guiding, and he used to give us the valuable advice from time to time and awareness about the stock level, and he was the man behind for the right product at the best price. And I would thank our medical superintendent also for judiciously approving the PPE, so and making the control of the PPE. And daily our job was to ensure adequate stock of personal protective equipment round the clock. So you all know that our procurement, there is a lot of process and it takes week together and months together to procure. But during this pandemic, we, without deviating, we procured all the equipments
and all the materials within a span of time. And there was a challenge of quality check of available stock in the market was a great challenge, and no compromise in quality for whatever reasons. So ensuring the working condition of equipments and accessories round the clock was a challenge, and our biomedical engineering has done a wonderful job. So ensuring the continuous working of the equipments. So procurement of life-saving equipments on immediate basis was required, and the management has given all the approvals on place, and we have done so. So getting the equipment was a big challenge, and that doesn't end there. So there was a calibration which required to start the equipment. So as you all know that person from Bangalore has to come for calibration, and there was a lockdown, there was no transportation. So we have to arrange the transportation, and we arranged for the passes from the police department, and overnight he came to our campus, and calibration was done, and the next day morning the equipment was ready to use. So meeting the additional requirements of oxygen, as you all know that we had a normal capacity of 10 working days as a backup, but in the peak of pandemic, it came to 3 days backup. So the relationship between JSS and the vendor, good relation maintained, that the vendors continue supply. As you all know, even in Bangalore, lot of bigger hospitals suffered a scarcity of oxygen, but really JSS, we maintained that, and I thanks to all the team and even the vendor too. So as you all know, the government was pressurizing to give the additional beds. So only providing cots or beds was not a challenge. So whenever there was an extension of new wards, so a lot of other things, procurement and the requirements were fulfilled. I would really thank to our maintenance department, IT, and all other people who worked day and night and fulfilled the same. Finally, so thanks to all the donors who supported by giving generous donations of PPE. So a lot of PPE like masks, so all the equipments and a lot of things came as a donations. This was a really oxygen to our management, and we could, by this, we could save the lives of a lot of people. So thanks to all our team, our management for all doing this, and thanks to you to provide me an opportunity. Thanks to you all.
So here just I would like to add on, that especially regarding the material management, under the guidance of our director, the finance was taken care by the chief finance officer, and the purchasing and other things were taken care by the purchase officer, especially not only COVID, non-COVID areas also. So it is a teamwork, and definitely I congratulate our administrative officer for taking care of all these things. Thank you. Thank you, sir.
Thank you very much, sir. Now I would like to hand over the session to Professor Smithashri.
Thank you, Mr. Harshit. Leadership is the art of giving people a platform for spreading ideas that work. We have with us one such leader today, Dr. B. Suresh. Dr. B. Suresh is the Pro-Chancellor of JSS AHER, Mysuru. He was also the founding VC of the deemed university. Sir is a well-known, distinguished, eminent educationist, pharmacist, and a leader. Words are less to describe his eminence. To see a few, he is recipient of many national and international...
I think we can cut that introduction, I think.
Sir, one more line to add on, please, sir. He also sits on the board of various national and international pharma associations and organizations. With this, a person with such eminence, it's my privilege to introduce to you Dr. B. Suresh. Over to you, sir.
Thank you for the nice introduction. Dear colleagues and panelists who are here, I know it's late in the afternoon, and leadership is the last thing which anyone would like to listen now. But having discussed with so many important issues that went through the day, I think it's good to sum up for the young students who are particularly doing the management studies program to understand what is the story they have seen so far. I think unless let us say in a movie, the director does not evolve the story fully, it looks all as the character of the individual characters have played their roles and goes away. So what I am going to do is now just edit a little bit here and there and give you a story back to you in a small summary as to how there is a great leadership role played by every person in this system which has provided the care. So let me take you through these slides. They are more factual rather than content rich. So let us look at it and see how we can take further. With this, I will share my screen. I think I am all set. You are able to see the screen, I presume, and able to hear me. So there is no issue on that.
Yes, sir.
Right. Yeah. So I was always amazed, whenever I look at the leadership that people have to give in an organization, I get always amazed. How does a person do so many things at the same time and see that everything falls in the place? And sometimes when you look up at the sky and see that there's a big universe out there, but somebody is controlling all these things. I think without that control, all these things should be colliding and we should not be existing. I think this is something where the leadership from the unknown source comes in the universe. I think similarly in any organizational setup, every person rises to the occasion and tries to become a leader and try to not collide with each other and move on with the things. So let us look at how these things got evolved. Now, in a leadership situation, always you have to look at the present position where you are, what is happening. And if you look in the period of our March to April, April to July, if you see, the whole health industry was in chaos. They did not know whether we will survive the pandemic, whether the world is going to come to an end, what will happen to the healthcare industry. You are asked to close down the hospitals. There is anxiety on one side, and access to the healthcare is going to be a problem. And all these were having impact. Now, nobody knew how long this will last. Everybody was talking next week, everything should be fine. But that next week was never happening. And now the whole thing has happened is there is a paradigm shift in the way we are looking at the healthcare itself. Now that was 3 to 4 months away back. If you look today, that today's Indian Express news says that 1 in 3 dogs falling to COVID, which was just mentioned by our learned speaker Dr. Nagendra Swami also. There's a high risk for the health professionals who are associated. On the other side, we are talking of the whole healthcare segment struggling when even you are talking of the economy trying to revive and go back to its feet. If the economy revives, but will the health segment be back on its feet? Because if it is not on the feet, when the people who have failed economy come back with more issues, maybe stress, maybe cardiac, maybe other problems they may have, they'll come back to the healthcare. And if the healthcare industry is not going to be in a good, healthy position itself, what type of care is going to be provided? So this is a problem today we are facing. What I told you 3-4 months ago was fear. Now even today we are in a situation. Now let us see what has happened at this very moment here. Just today morning I was going through and a message comes, the greatest democracy of the world, the United States, the head of the state is COVID positive and his wife is COVID positive. Now again we have another democratic head, the largest democracy, our prime minister wishing the president of United States a quick recovery and good health. So this is showing one simple thing, that how this crisis is leading and where it is going to the next moment, we do not know. Now if you look at a country where which is going to the most powerful country in the world, and if the head of the state is going to be in a situation where he has to isolate himself from carrying out his roles and responsibilities, the leadership of that country, how is it going to be affected? I think this is something we all have to learn. Now, for all that is required is the position I explained to you all. What is required is, do you have a plan? Do you have a plan for surviving this situation? I think that is where the whole thing is worked, and that is what JSS did. When Dr. Dayanand spoke to you, he spoke to us very clearly in the beginning, telling how in January we heard about this Wuhan issue and how in March we had prepared that we will respond, but we'll respond responsibly, not just try to tell, okay, we are ready for everything. And we were started preparing in the back. So this is the plan which we were talking about, and you could hear how each one of them, whether it was Dr. Dayan talking about the expanding, Dr. Basangodappa speaking about putting the team together, Dr. Ravi talking about preparing the SOPs and protocols that have to go, the ICU getting ready, the equipment coming in place. This was all a plan ready for you. So that is why we feel at JSS not fearing the brunt of not having something which you cannot manage. I have got great leaders here. We have got great leaders here who put things in the right plan so that we are able to move smoothly. I don't think we came back running to us telling that we don't have this, we don't have that. We always planned something ahead of time, and that is what was helping us to do it. We could be led by the expertise of all these people. We mobilized the collective effort together. Dr. Sumulata showed how she mobilized even the nurse in the ward to help her to achieve the outcome which is required. And the whole idea was to enable cope with the whole situation and move forward and not complain that I don't have this or don't have that. And that is what the plan gave us to move forward. Now, if it is looking at the perspective, after you have the problem or position and you have the plan, now look at the perspective. Now, how enormous this whole thing matter is. I don't think anywhere in the world anybody has seen such an enormous risk where 7 billion people are afraid at the same time. Let us find any one person anywhere in the state, you ask him, are you not afraid of corona? Though he may say boldly, yes, I am not afraid, but the moment you try to bring a contact a patient with him with corona, you will find him running away. So that means all 7 billion people in this world are afraid at the same time. The whole economy is at the stake. Now, is this not the time that we as leaders try to provide something which can keep these 7 billion people going forward with some hope? I think that is what all this leadership is about. The world has never experienced something like this, and it will not going to experience like this in another maybe few decades at least, because if it happens, God forbid, we will not be able to sustain the challenge. I am sure now people have got used to this little bit and they are trying to cope up, but if you try to bring them some other challenge of the same type, I am sure they are not going to be able to face it. So it is then you find people trying to become leaders. I think this is where you are seeing, you find all the leaders doing different things, including our own leaders at JSS. I don't know how they got into the list of all these world leaders. I think their work is so emulating that they also have found themselves in such a position. As far as JSS is concerned, they are our leaders and they are doing wonderful work. So it's only right that I congratulate them. When we talk of people, there are different types of people. We have strong people and we have the weak people. The strong people are the people who take over the charge of the whole situation and try to say that let us do it. We'll try to work all together, and they don't run away from the battle scene and stay at home and say, oh, it'll get over, somebody else will find a solution, we will do it. These people stand in front every day and try to see how things can be solved. And that means, what do we mean by solved? Keep the right information to the people, whether it is the patient, whether it is the relatives of the patient or the staff. Speak the reality to them, speak to them the truth, and then inspire cooperation and confidence. Tell them that we are with you, don't worry about it. And produce and distribute scarce resources that may not be available, maybe tests, maybe personal protective equipment, ventilators. You saw like how everything was there, and every day meeting which you used to have with the director, Dr. Basangodappa and the team, they would come and say, we need ventilators, we need PPE, we need equipment, we need oxygen flow meters. So everything was coming up, and we could not at that time ask what cost it is. We had to tell how many do you need to keep going, and that's how we have responded. And this is a greatest step, and the people have to look at this. So people play a very important role in leadership. Then comes the preparedness, and that's what we spoke about. What was the strategy put together? How did we put the people to the place together, ensuring that the workforce and personnel have all the requirements, converting the whole units into a COVID unit. It's just overnight if you want to change, ensuring that there are an adequate number of tests and ventilators available, redeploying clinicians and staff. All this requires a lot of background work. It doesn't happen, you just walk into the hospital and do it. And that's where the healthcare administrators take the major role, and they take decisive and immediate action, and the choices they have to allocate and the resources they have to manage. They put out their priorities on the day, how it has to be done, and move on further. Communication within the organization and to the public is a key effective way of the management, and that is how our JSS hospital has been responding. So I think this is the next point I would like to say. Now, after the preparedness comes a real leadership. Now, when we talk of all these things, the leadership, the leadership requires a long-term approach. Yes, the immediate needs of ventilators, oxyflow all are fine. But the long-term, the real leader would look at a long-term approach. Even when we were discussing, we were clear that this pandemic is not going to be over in a week. We knew that it may go up to December, it may go up to even the next March. But let us plan in such a way that we are able to cope up as it is good. Just now we heard many people speaking, November is going to be a crucial period for all of us. Now we have to get prepared for that and see whether we have enough resources to tide over this November also. And that is what is all about leadership. Anticipating what comes next. November, is it going to be a challenge? So what will be our response? Will we be equipped, or will we be running short of our, again, resources and have a problem? So this is something we have to look, build a team that can manage us and keep us going, and look beyond the immediate crisis and to plan for the future challenges of the organization. I think this is what is all about the leadership which we are talking about. And if we look at it, when the world is talking of problems, there are going to be problems. Always problems will be there. There will be a financial fallout. Now, right now, we are not counting our pennies and trying to find, are we making enough? Are we able to sustain? That's a secondary issue. The issue is, are we able to keep moving on? And that's where the focus is. And perhaps I can tell, even in the first picture which I showed, first slide I showed, we are in the situation. Our hospital is, and our organization, only organization, there has been no salary cuts or people being laid down or people being told not to go out, to go away, because we felt this is the time when we need people. This is the time we need to keep the people inspired and going, and not at the time of look at money and try to reduce how we can cut costs here. The money would automatically come in when we need later. But right now was the things to keep things going on. And there will be a pent-up demand which will happen, as was being repeatedly told earlier also, that this is, after this is going to be over, there is going to be a lot of other challenges that will come, and these problems also we need to manage. Now, this was the future that was predicted by one of the biggest magazines, Forbes. They talk 2019 December is going to have a big, the healthcare industry is going to change. Now, all these predictions have gone out of window. So all this has come to a pause. Now, what will happen? There will be new calculation, new ideas, new things that will take the shape in the world. And that's what we were talking about 2025, how things are going to happen. I think this is something for all of us to think. All these predictions which people were made about health industry has to be redefined. What they talked about NCDs, non-communicable diseases, as an important step for them to carry forward, will now change to infectious diseases and look at how these infectious diseases are going to play a problem. The whole pharmaceutical industry will have to rethink about infectious diseases. They will have to think about vaccines. They will have to think about immunology as a more determining factor. I think these are all going to be the future changes which we are going to do. Now, what will be the perspective? What will be the future? I feel very strongly with hearing all this wonderful talk which we heard this just now this morning. I think JSS Hospital will emerge as one of the most respected, reliable, research-driven healthcare provider regionally and nationally. I think this confidence, I don't have even an iota of doubt on that. The leadership provided by the healthcare team here will be recognized for its care, innovation, and inclusiveness. the affordable and accessible healthcare that provided at the hospital will make it as one of the most preferred facilities by all stakeholders. I think this is something is what I am looking at the future. The good work that is happening is going to bring really JSS Hospital to the next level, where we will indeed be very proud that we were associated with this, such an organization, and we are able to continue to provide the care. Even now, you heard this morning the Deputy Commissioner coming and speaking to His Holiness Swamiji, telling that we need more support from JSS Hospital. There are several other hospital systems in the Mysore district itself, but why JSS? Because the good work which you are doing is being reflected at all the places, and that is what is required. So you have to think that being a leader is not going to be a simple job. All of you are leaders. And before I go to the thank you slide, remember that leader believes. He believes in what he does. Leader inspires. He inspires everyone around them. Leader listens. He listens to everyone's problems, issues, and tries to see is there something he can do about it. Leader learns. He learns every day something new, and he does something what he wants to do. A leader cares. He is always compassionate about his colleagues and sees that how he can help them. A leader empowers. He gives them the decision to take forward the activity. A leader unites. That means he brings the people together as a team. A leader guides. He shares his experiences, and leader leads from the front successfully. I think you all as students of management should understand that if you want to be a leader, if you want to go forward, I think these are the qualities you have to learn while you are studying, experience while you are in this hospital, when you are learning in the hospital. I think this opportunity is not going to come to you again, and this cannot be a better learning place than for you to learn. And let the JSS continue to lead is what I would like to say. And thank you all for your patient hearing. Thank you.
Thank you, sir. And we are really fortunate to have leaders as you all, and blessed to have the blessings of His Holiness Swamiji. And I know it has been a delayed sessions, and even at this hour, in fact, your speech inspired us, enlightened us, and we all have learned a new lesson in management, that is putting the right effort, learning from experts, avoiding extremes, evaluating according to results, and follow the path of right conduct. And definitely we are fortunate to be associated with such a blessed organization, sir. And thank you on behalf of the Department of Health System Management Studies. We wholeheartedly thank each one of the resource persons and members of the organizing team and the IT team and our secretarial assistants for having made this webinar a successful one. Thank you so much, sir.
I think I would also like to thank here His Holiness Swamiji, because he has been the inspiration behind whatever is happening. And when we went behind and when we met him at each situation, when we wanted to move forward, he was always there to listen like a true leader. And he will ask us what you want to do, and you will say, go ahead. There was no other such a thing, anything else. You just listen and you will say, you'll go ahead. I think you cannot have a better inspirational leader than His Holiness Swamiji, who has given us. I think Dr. BG can endorse further, or again, my colleagues there in the boardroom at the hospital, they will be able to endorse further.
I fully endorse your expressions about spiritual leadership and the guidance given by Swamiji. And for all the good cause, whenever we approached the academy, university, and the hospital authorities, and which went to Swamiji, ultimately it had not taken a delay of anyone a minute. If that is a good cause, that has been approved. And that's why the things have been gone on, they have gone on very smoothly. If there was a dilly-dallying and delay, these things would have moved, would not have moved in such a smooth manner. And everybody has presented very well, and hard realities have been made known to all the stakeholders here. And HSMS has to be complimented for designing such an exhaustive webinar. And thanks for your leadership, sir. It was a fantastic summary and presentation by you.
Thank you, sir. If any other member wants to express their suggestions or opinion, otherwise, shall we close the session, sir?
I think all of us are hungry.
You can tell all the speakers to just reply to some of the specific questions which were asked to them by mail or by this opportunity platform only. It's already delayed.
Yes.
There will not be time for interaction. Thank you for organizing this webinar.
Thank you, sir. Thank you for all your support and guidance, sir. Thank
So
you.
congratulations to
Thank you,
HSMS for a very good session and a very good seminar.
Thank you, sir, for leading us from the front.
Thank you, sir.
Thank you so much.
Thank you, sir.
Thank you.
Thank you all. All the best.
Thank you, sir.
Thank you, sir.